Hello and welcome to today's webinar. Thank you so much for taking time out and being here on Sunday morning. And my name is Ayong. I am the host for this webinar. I am also the marketing and educational seminar coordinator here at NeoBiotech. And welcome for today's webinar. Today's agenda is very simple. I will introduce our topic and presenter, and also we will have a short 5 minutes break during today's webinar today, since it's a long webinar. And also I will make an announcement right after the lecture in regard to upcoming webinar and watch previous webinars, and also how to receive your CE credits. So please don't leave and stay until the end. Today's topic is the myths and facts on guided implant surgery. Implement implant surgery into your practice with Dr. Spenser Park. And also, we are strongly recommended to use the chat box right here to communicate with me if you have any technical issues. And other than the topic, we will have a Q&A session at the end. So please use this Q&A box to submit your questions, and Dr. Park will answer your questions. So let's have Dr. Park to start today's webinar. Good morning, Dr. Park. Hello, Dr. Park. Can you hear me?
Yeah, I can hear you. Thank you very much for your kind introduction, Ayong.
No problem, Doctor. Please take over. Thank you.
Sure. Good morning, everyone. I hope everybody is doing fine, and thank you for coming to our webinar in Sunday morning. Right. I know it is quite difficult time, including myself, but webinar is one of the way that we can still keep our clinical skills sharp as much as possible. Today we're going to discuss about guided implant surgery, and I would like to share my experience as a developer and as a researcher and also as a salesperson, right? But in order to give you proper information and knowledge about the guided surgery, I have to start with some basic concept of the implant surgical protocol of NeoBiotech. So it's going to have a three part. First part is going to be implant surgical, the protocol and then concept of NeoBiotech. Second one is stability, and then we're going to discuss about guided surgery. So good point and bad point for that one. So now let me share my slide and let's start. All right. Okay, so I used to teach in UCLA for about 15 years as a postdoc faculty, and then I joined to the NeoBiotech and a couple of the other company, and they work as their clinical research consultant. And now I'm also work for as a NeoBiotech USA president. So today I'm going to share about what is NeoBiotech, and then what is the GAO very quickly, and then we're going to talk about the implant stability, and then we're going to talk about how to achieve our implant stability, and then we discuss about the protocol and how to measure the implant stability. So those are basic concept of the implant, the surgical protocol, and based on that surgical protocol, then I'm going to explain to you how we use those concepts into our guided surgery. So let's talk about the NeoBiotech. Well, NeoBiotech, if you ask me what is NeoBiotech, what kind of company it is, then I can tell you that is ongoing history of continuous innovation on clinical demand. Well, for the last 10 years, NeoBiotech produced a lot of the product, and some of them is really innovative and then really popular in the clinical situation, but some of them has a great concept but not really welcome. But point is that NeoBiotech, we are based on every product is based on the clinical demand. So here, the Dr. He, who is CEO of the NeoBiotech, he is also prosthodontist and is good friends of mine. So he and me and about 5 different doctors, directors, we're going to see the patient pretty much every week. And then when we see the patient, once we find some difficulty, failure, or complication, and we try to find out how can we solve the issues. So a good thing about NeoBiotech product is everything is based on the clinical demand, and then it was designed by the doctors. But bad point is we have some learning curve because those doctors, including me, has just have some high expectation that our colleague doctors, dentists, has some skill and experience of that. So when you're using the NeoBiotech product, I sincerely recommend that please read the instruction, how to use the kit, how to use those tools. So please read manufacturer's instruction, and then sometime you can watch on the YouTube and then spend about 5 minutes or 10 minutes to understand the concept of the product and then practice a couple of times and then use in the clinical situation. Then no problem going to be happening. And also, I'm like to share some information about Global Academy of Regeneration. So if you have a time, you can type out gaoforum.com and then you can access those clinical data. So about 35 nations and then about 12,000 members, and we share those information together. So to get the ID and password, please contact your sales representative and then they're going to share with you about that, right? So now let's get to the business, all right? So let's talk about the implant stability, right? So the biggest question is when to load a dental implant, because when I when I talk to my patient about implant treatment, and then usually my patient asks me that, Doc, when can I have a crown? When can I chew? Sometimes even before putting the implant, they ask me, when can I have a crown? Right? So usually I do not give a correct answer. So usually mandibular maybe 2 to 3 months or 1 to 2 months, maxillary 3 to 4 months, depend on the bone graft and the individual healing time. So I try to avoid the exact time because I don't know, because I really don't know. I can give you some average about healing time and then prosthetic the application time, but I cannot give a specific time in the individual, right? However, in the bottom of my heart, what I really want to tell my patient is, hey, do you want to have an implant crown now? Then here. Do you have a crown next week? Here. Do you have a crown 1 month later? Here. So anytime you want, I can give to you, right? That is the real answer that I wanted to tell my patients. But the question is that, does anytime loading is working? Yeah, I can put the crown, but a couple of days later, it was failed, and the patient bring the crown with their hands, with their fingers, then it's not working. So those anytime loading is working. How to make those anytime loading is working is a basic concept that NeoBiotech has been working on for the last 10 years. So when we look at those uh, determining factor of the dental implant loading time, right? First one is patients need, want, compliance, occlusion, medical dental history. Yes, we know that. And also to put the crown on top of the implant, we have to talk about the soft tissue, right? Make sure soft tissue healed and matures properly, especially anterior, and carotenoid tissues, proper carotenoid tissue, those, etc. And also hard tissue. We want to make sure that our bone is healed properly. And also, is there any infection before that and then any osseointegration need to be properly done, right? Then we know that hard tissue is ready. And then also we need to check the implant stability. Everything is fine, but your implant fixture is moving. Yeah, there's no way we can put a crown on top of it. So among all those things in the clinical situation, the main determining factors is implant stability, if everything is fine. Then let's talk about why implant stability is really important. Well, based on 2008 article, they're saying that achievement and maintenance of the implant stability are prerequisites for successful clinical outcome. When I was a resident, I was told it's optional, but if you achieve the good implant stability, that is really great. But if it's not, then leave it alone. Do the two-stage surgery, you're gonna be still fine. However, not anymore. It is not optional. Achievement and maintenance of implant stability are prerequisite. I just want to make the point out of that. Then what is the implant stability? Based on the JPD, right? Their definition of the implant stability is that they talk about the force. And also they talk about the endurance. So when they talk about the stability, they talk about the characteristic endure against some force, withstand against some force that was applied on that the fixture. And also they pointed out that primary stability is a purely mechanical stabilization, okay? So when we talk about the stability, we talk about the force and we talk about the endurance against that force. Based on the AAID, so American Association of Implant Dentistry, their definition of implant stability is like that. It's the absence of the clinically detectable implant mobility. So now when we talk about the implant stability, now they talk about the implant mobility in their definition. And also they told that secondary stability is a biological engagement between bone and implant surface, right? So to me, it is my humble, the definition of the implant mobility or implant stability, actually they are same thing. Implant stability, implant mobility, actually that depend on how we look at it. When we place the implant can be moved up and down, we don't want it. When we place the implant, your implant is mobile laterally, we don't want it. When we place the implant, our implant is tilting like that, yeah, I don't want it. And also our implant can be just rotating. So those mobilities, basically measuring those mobilities, in other words, measuring the stability of those implants. Bottom line is once we place those implants, we do not want to see those mobility in patient's mouth. And even when we put the crown on it, we do not want to see any mobility like that. So my humble definition of implant stability is the absence of the fixture mobility under the physiological force from mastication. So when patients chew on the crown, I do not want to see any mobility of this one, right? So measuring stability, in other words, is measuring mobility of the implant. So when I was a resident, right, that is about 20 years ago, and then when I was taught about the implant study, implant loading, and then the also integration, excuse me, this is what I learned at that time, right? And then this is what I've been taught for my student for a long time. So as you can see over here, we have a primary stability and also we have a secondary stability. So primary stability is basically mechanical fixation. So when we start with primary stabilities, so first we achieve about, for example, 50% or 60% of the primary stability, everything is fine, but those bone around the fixture was damaged. So our osteoclast going to go there and they're eating up those damaged bone. When they are eating up those damaged bone, we lose those fixation, then the primary stabilities drop down, as you can see on the orange colors graph. However, at the same time, once the osteoclast eating up those the damaged bone, then osteoblast going over there and then building up the new bone. So when those new bone was matured, then we can achieve those secondary stability. So in total, we're going to have those total stability. However, as you can see, between 2 to 5 weeks or 2 to 6 weeks, we can see those the dip, so-called stability dip. So when we have those stability dip, that means our implant stability is not that great. So we call that is a dangerous zone. So my professor told me that, hey, don't touch that implant. Do not touch the healing abutment during that time because that is the weak time. If that is true, then there's always stability dip, then the immediate loading or anytime loading is not possible. So NeoBiotech and I try to work on this, the graph. How can we manipulate it? So this is what we dreamed about it. Can we change this graph from conventional stability pattern to the new stability patterns, right? Is it possible? Well, this is what we dreamed about, and let's see how much we can achieve so far. So again, the initial stability pattern for those conventional is like that. However, when we have a better mechanical fixation, in other words, the implant design, the macro design is better, then we can achieve that high stability. So then we can have a better torque, right? And then we can have a better stability. Problem is when we have a better initial fixation, still our bone is damaged, and then osteoclast is going to be there, and then it's going to be dropped. So even though our starting point is a little bit better than before, but still we're going to have those drop that don't help us a lot, right? How about this? As you can see on the dot graph, we can shift our graph to the left, to the right. In other words, what if we can use osteoporosis medication like that? So those osteoporosis medication compromise or stop the implant, the osteoclast activities. So because there's no osteoclast activities or very little osteoclast activity, then hopefully they're going to be the stability going to be maintained. Problem is when we know that those osteoporosis medication like bisphosphonate can cause osteonecrosis of the jaw. So it is still quite dangerous. And then I believe personally, maybe in 5 minutes, in 5 years, or in 10 years, maybe we can see some results, but still it's too dangerous using that osteoporosis medication to increase the implant stabilities. How about this? Those are purple dot. Well, this one is very simple idea. When we make the hole, when we put the implant, we make the hole. When we make the hole, basically we damage the bone. When we damage the bone, more damage means that more osteoclast, that means more loss of the stability. So what if we damage very little? Minimum damage on the bone, then osteoclast activity also going to be minimum. Then maybe we can decrease the stability dip as much as possible. So in other words, if we achieve that the better growth, the design, implant fixed design, and then with those very minimum, the osteotomy protocol, maybe we can achieve those pink graph. That is what we dreamed about it. So better fixation by have a more aggressive implant fixture design, and also more conservative and non-invasive osteotomy that may result in the less activity of osteoclast. So in order to achieve the NeoBiotech, we have those two options. So better mechanical initial fixation. NeoBiotech, we talk about the CMI fixation protocol, and then also less amount of osteolysis, less bone damage. And then I'm going to share with you guys about anti-thermal damaging osteotomy and also the CMI fixation, and then also the flap design. But the question is, what is those CMI fixation and anti-thermal damaging osteotomy? So let me share with that. All right, CMI fixation. What is CMI? So C means this for the coronal, and the M means middle, and I means inferior or apex. So as you can see over here, the CMI over in the first diagram, you can see that all the bone is the coronal area, you have a bone, middle area, you have a bone, inferior area, you have a bone, right? But the difference is this. Usually when we talk about the implant case, then, hey, do your patient has enough bone? So we talk about bone dimension. Hey, vertically you have enough bone, or horizontally do you have enough bone? We talk about that. And then we talk about, hey, what kind of bone do you have? Do you have a hard bone and soft bone? So usually we talk about the bone dimension, and then also we have a talk about the bone quality and quantity, those two. But CMI fixation concept is instead of doing that, let's be more specific. we want to see that how much bone you have on the coronal aspect and how much bone you have in the middle aspect and the inferior, and then what kind of bone quality do you have in CMI, those three different location position. Because as you can see on the first one is you have a hard bone on the C and the mid and the inferior, you have a less dense bone over here. In the second picture, as you can see in the sinus elevation case, we have a no bone on the inferior. Or even more, the severe sinus elevation needed, then we have only bone on the C coronal aspect. Or in an MI situation, we have no bone on the crestal area, right? Usually this is happen when we place the immediate placement after the extraction of the tooth, right? So first thing is, let's look at the bone quantity depend on those three locations, right? And then third one is, let's look at the bone quality. As you can see, all those four cases, we have enough bone, right? Vertically and horizontally. However, when you look at closely, first one is everything is really hard bone, dense bone. A second one is only coronal aspect is hard bone, the other bone is less dense bone. The third one, as you can see, everything is basically very less dense bone, like posterior, maxillary posterior, right? And then the last one, we can see those cases frequently in the mandibular anterior. So that means we have a hard bone, dense bone on the top, and then dense bone on the apex area, right? So bicortical fixation also can happen. So the question is that, do we want to deal with for those cases like same, or do we have to deal with differently, right? Answer is very clear, right? Those four are different animals, right? Different bone, even though they have a same amount of bone quantity, but in terms of quality, they are totally different. Since they are different in terms of bone quality, then our osteotomy procedure protocol must be different based on the bone. That is about the CMI fixation concept, nothing new. So as you can see over here, that is our final osteotomy. So if you have a type 2 bone situation, that means you have a dense bone on the top about 1.5 millimeter, and then you have the less dense bone on the bottom one, right? Then we intentionally make our osteotomy diameter is very small, right? And then right before place the fixture, we do the partial tapping. That partial tapping is only on the dense bone, hard bone, right? And then we place the fixture right there. And then as you can see over here, on the dense bone area, hard bone area, we do not put any pressure on it. However, in the trabecular, soft bone area, we press the bone, we push the bone, and then we try to achieve some compaction over there. So that is about the type 2 bone situation with CMI. So in other words, like that. Most of our conventional implant protocol is like this. We do the kind of countersink, and then we place the implant, and as you can see, only the hard bone area, there's just some engagement. But those engagement area ended up the stress concentration on the last figures, right? That is about the finite element analysis. When those stress is concentrated, and then what happened to that bone? Because those bone is stressed, and then they want to relieve their stress, then they're gonna call the osteoclast, and then they're going to lose the bone on that one. That's why we lose the stability. But if I'm using the CMI fixation, then by pre-tapping means that the pre-tapping drill size is exactly same as the implant or fixture shape and then diameter. Shape and size is exactly same as the pre-tapping. So in other words, on the hard bone area, we do not push the bone, but there is the better engagement without losing the bone. So it ended up, we have a better distribution of the implant. Right, so now let's look at the more different way, conventional versus CMI fixation. So let's look at this figures diagram. As you can see over here, if we place implant conventionally, and we can see that there's a lot of stress concentration. that stress concentration ended up the high possibility of rapid and large amount of the osteolytic bone remodeling due to the high stress. In other words, yes, we can achieve that the torque stability. However, it can be ended up the losing those stability very quickly because of the bone remodeling that caused by the stress concentration. But if we do the pre-tapping exact shape and size of the fixture and we place the implant, then it's gonna be much better because there's a very much better stress distribution. And also from the bone's point of view, those areas, the bone need to remake it, right? They have to regenerate it, and then they have to mature it, and then it need to be also integrated. So that's why it takes a long healing time. So excessive amount of bone damage and loss resulting in a large amount of new bone formation and maturation and longer remodeling time. So bottom line is so try not to remove the bone that is not really necessary. So let's remove the bone only what is needed. So in other words, when we look at the conventional, when we look at the final drill that is available at this point, as you can see, some of them has a full tap, some of them has already built in the countersink drill over here. So why we are using those countersink, right? Again, so let's go back to this slide. Why we used to have those conventional concept before? Because about 30 years ago, when those initial implant was in the market, every drill kit has a tap drill, if you remember. So then doctors going to put the implant, follow that protocol, but sometimes those tap drill, we have to use about 50 RPM, but sometimes my assistant didn't follow it, forget it. So I ended up grinding 1200 RPM. So I messed up. But sometimes when I place those implant, but the tap drill, I cannot hold my hands steady. So it's going to end up the wrong position. So it ended up ruin my implant position and then the angulation. So doctors complain a lot. Hey, tap drill was not really easy to use it, right? That's why all those implant companies try to move away from the tap drill because it's gonna cause a more clinical complication and then doctors complain about it. So all the company move from the tap drill to the non-tap drill, from tap drill to the countersink wise. But now we have a guide over here. So in 2020, guide is available and then it is quite reliable. That means with the help of the guide, we can control the position and angulation of our fixture. Then it's going to remove a lot of complication. That's why those CMI fixation I want to revisit and I want to share with you again. Right. Okay. Then let's talk about the torque. So to talk about implant stability, we need to talk about the torque. There's many different definitions: insertion torque, seating torque, and then however, in this day, when we talk about the final torque, is the highest torque that we place at the last moment of implant placement, right? So here nowadays we talk about final torque, seating torque, insertion torque is kind of same, right? The terminology. However, there is two different idea about insertion torque. In 2009, the Michigan group, they reported the case. That is, without any issues, any complication, by mandibular implant, after 3 months after those placement implant, they find a lot of bone loss around the neck area of the implant, even before the loading. So they thought that those bone loss around the implant is because of the too much torque. When too much torque happens, then those bone is compressed. When those bone is compressed, and then those bone ended up the necrosis, right? Well, 2011, there's different group, and then they did animal test, and then they shows that even though 90 Newton centimeter or 100 Newton centimeter, there's no compression necrosis, right? However, when 2009, those compression necrosis published on the implant dentistry, everybody was really worried about it, and all the company changed their protocol, right? So 40 Newton centimeter, 50 Newton centimeter, as you can see, that is what we need, right? But the question is really true? How possibly those two articles, those two groups has a totally opposite way to look at those, the compression necklaces. When I look at carefully, and then this is my little humble research, and then what I realize is that those two articles, well, they did not mention about how they got those torque. If they got the torque by compressing, by pushing the hard bone where there is no gap between the bone, then those bone has no way to move, so they're going to be compressed over here. So if the compression is more than 50 Newton centimeter in dense bone layer, then possible compression necrosis or excessive bone remodeling going to be happen. However, as you can see over here on the soft bone areas, right? When we press the bone, still there is a space between the bone, and then they're going to be compacted instead of the compressed. So when they compact or more dense, right, condensed, and then it's going to give a better torque and the better stability. So over here on the right side, you can see the three-dimensional, the bone, the images. This is a femur of the mice, and I placed the mini implant on the top. But as you can see over here, there is a lot of space within those trabecular area. So based on my humble limited research, and then when I push the hard bone, 50 Newton centimeter is a limit. Do not go over that. However, if we compacted the soft bone about 75 Newton centimeter, still there is no issue at all. So I'm going to share with you guys for that clinical data. So bottom line is the number is important. Yes, number is important, but more important is how we got those numbers. Where we got those torque is more important. Did we got those torque from the hard bone? Or did we get those torque from the soft bone, right? So take-home message for you is this: let's respect the hard bone. Do not push the hard bone. If you need to push it, instead of pushing, let's cut it by using the tap drill. And then minimize the compression on the hard bone, right? That is the bottom line. So now let me share some of the results that I have, right? Let's look at the middle one. So in this case, I used the IS3 implant, and I placed the implant 4x10 implant, right? 4 millimeter diameter and 10 millimeter length, right? And then the drill size of the diameter is a 3 millimeter, and then 3.5 millimeter and 4 millimeter, as you can see on the middle table, right? So basically what I did is I did the under-osteotomy or proper osteotomy or over-osteotomy, over-drilling. And also I did a tapping and no tapping. And then I checked the torque. But as you can see over here, 3.0 no tapping, 3.5 no tapping. Still both of them are more than 80 Newton centimeter. That is quite high. So my point is that the final drilling size is not really critical whenever you have a hard bone. So the determining factor is over here, the tap drill. So when you have a hard bone layer, like type 2 bone, in that case, whether you have a tap or not, that is more critical. So 3.0 with the tap drill, it ended up 61 Newton centimeter. 3.5 and tap drill, it ended up 50 Newton centimeters. Then what is the difference between 85 and 61? That is about 24 Newton centimeter is from the hard bone. So by pre-tapping it and we remove those hard bone fixation situation, then we can relieve the future, we can prevent any compression necrosis or the very rapid bone remodeling around the hard bone. So I just want to tell you that the importance of the tapping. Now, let me share with some of the clinical case that my friend shared with me, right? So over here on the left, you can see that the implant placed, and then my friend put some crown on it, and then immediate loading was done, February 11th, right? And about 10 days later, patient complained a little bit of the discomfort, and then he took the x-ray, and then you can see a little bit of the radiolucency. And about 10 days later now, patient has more pain and then more mobility, and then my friend removed the crown out of it and then put some healing abutment, but you can see already there's radiolucency happen. And then about a month later, whole bone is gone over here. So this is a very typical radiograph image of the compression necrosis, right? Then why this thing happen, right? So my friend just thought about it. My friend, when he looked at this case, when he received this case, and hey, this is a trabecular bone area by anatomical structure, so he didn't pay attention to the bone quality itself. How can we tell? Over here, in the second radiograph, you can see that the root of the tip, root of the neighboring tooth, and then bone over here is very similar in terms of the radiopacity, right? So in other words, those bone is, even the location is trabecular bone pattern area, but the bone itself is really hard bone. So my friend, what he did is he didn't do the full tapping, right? So he didn't respect those hard bone. Basically, he placed the implant and then he got some torque, about 70 Newton. Then he turning back 2 to 3 times clockwise, counterclockwise, and then put it back and then back and forth. And then once he achieved about 40 Newton centimeter, and I'm good. And then he placed those implant. And then he put some crown on top of it. But the problem over here, when you do the back and forth with the fixture, right, then you're going to decrease the insertion torque instantly. However, we know that our bone is flexible, right? So when you do the back and forth with the fixture, right, basically you expand your bone temporarily. Once you place the implant and put some crown on it, but our bone going to back to its original dimension, and then all those stress going to be going back to the implant surface, and it ended up a lot of the bone compression and ended up those compression necrosis, right? So bottom line is why this case happened, because my friend didn't respect the hard bone and he didn't cut the hard bone. He pushed the hard bone. It ended up with the very rapid osteoclast activities, right? How about this? So another case anterior, he placed the implant and then he going to put the temporary crown right after the surgery. However, as you can see, let's compare those fixture, the white part, and then also root tip of the implant, root tip of the tooth, and also let's look at the bone. As you can see, all of them are really white. In other words, especially this patient has a really, really dense bone all around it. And then he didn't pay attention to it. That's why those bone removal happened and necrosis of bone happened over here. So this is also another typical case of the compression necrosis. How about this? Right, so he removed those tooths from the air and then he placed the implant. But now let's look at the bone. On the PA, you can see that how dense that bone is, right? So always, I strongly recommend you to compare the bone area you place implant bone and then compare that bone density with the neighboring tooth root. So if they are very similar to each other, that means your bone is very dense, no matter what the location over here, right? So again, this doctors placed the implant, it ended up compression necrosis, all the bone is gone, right? So it ended up, he removed all the bone and then he put some bone graft and then say a lot of sorry to the patients, right? How about this case? Even maxillary premolar case, as you can see, those hard bone can be happen. So we have to be very careful in this day. In the mandible over here, right, you can see really white bone around the implant. That area is specifically very hard bone, and then this doctor didn't pay attention to it, so he compressed too much hard bone. It ended up the bone loss like that, right? So I want you to keep in mind. And also let's look at, also let's look at this CT scan. So when we do the CAD/CAM design on the CT, right, over here on the left, as you can see, my implant is engaging the hard bone, so it's going to be much better. the truth is this is not a really great situation because most implant, if you don't do the tapping, then those hard bone going to engaging the implant fixture immediately and it's going to pushing your implant to the buccally, right? So if you want to engaging the hard bone like this on your left one, the lingual aspect of it, that means you have to do the tapping over here. That is what is needed, right? So if you do not want to do the tapping, then my sincere recommendation is instead of engaging the lingual hard bone on the left side, let's put implant on the center like that. So make sure your implant is on the soft bone area, right? Right, that is much easier and then the most predictable. If you don't know how, if you have very little experience about the implant placement in the hard bone. So overall, CMI fixation concept is basically, I want to minimize the bone damage, right? And then by control those compression and also by controlling the pressure on the hard bone and soft bones, right? That is what I can tell you. All right. Now let's talk about the heat. All right. Why heat is important? Because in the conventional way, we open the flap and we use a lot of irrigation solutions. So there's gonna be a lot of cool down. So it's not a big issue. However, when we start the guide surgery, the guide surgery is basically a big chunk of the plastic resin. Then no matter how hard you try, you're going to have a very little irrigation that reaches the tip of your drill. So it ended up causing the huge hit and then it can cause some issues. So let me share the case with you. On your left side, you can see that the radiolucence at the and on the apical area. This is my case, and then when I placed the implant about 1 week later, this patient came to me, and then he just pushing the under her nose, and then tell me that, Doc, when I push under my nose, it hurt, right? Without touching it, it doesn't hurt. So I told my patient then do not push it. However, that bothers me, and I took the X-ray, and then as you can see over here, I have a very acute radiolucence on the apical areas. When I place implant, there is no such a thing, right? Right? And then on the right side, as you can see, of a different pattern over here, right? So the bottom line is this. This is what radiolucence happen over here. This one hold the radiolucence happen over there. So on the left side, you can see those are thermal necrosis, right? And on the right side, you can see this is compression necrosis. So compression necrosis is more like conical shape, right? However, thermal necrosis is more like the endo region, right? Endodontic region. So you can tell that by that. Why that end happened, I'm going to share with you later, very soon. But based on those one article, what they told me that if the temperature of the bone is 44 Celsius, heat damage is going to be, permanent heat damage going to be on the bone. So if you have a longer exposure, then the area of the damage area is going to be larger, right? But still, 44 Celsius or about 42, 45 Celsius is kind of threshold where the bone going to be permanently damaged. And then that 1990, the article also showing that if you are using the 2.2 drill, twist drill without any irrigation, the temperature can be up to 84 Celsius. Well, even with the water, it can be go up to the 48 Celsius over here. So 84.3 Celsius is almost, we can boil the egg with that temperature. We know that's quite hot, right? That's why they told us the advantage of the using point drill, right? So, and then also they told the sequential increase of the drill length, right? If you do the whole osteotomy in a long time, that's gonna cause more heat. That's why they recommend the sequential increase. And also at the end, they also show us that if you're using the irrigate those area with cold water, or cold irrigation of about 5 seconds, that is perfectly cool down and decrease the damage as much as possible. So when I look at those last part, and it was enlightened my mind. Because usually when I do the third molar extraction or surgery, after the surgery, I gave my ice pack to the patient. And I told my patient, hey, put those ice pack until the night, right? And then those ice pack going to decrease your inflammation, and then pain going to be better, swelling going to be less, right? So my point is that then why not we are using those cold irrigation solution even during the surgery, right? Since we are trying to using the ice pack after the surgery. So what should we do? When you do the implant surgery or any kind of surgery, my sincere recommendation is put your irrigation solution in the refrigerator, right? Not freezer, right? About 50, 500 ml or small package of the irrigation solution put into the refrigerator, and right before surgery, you take your assistant gonna take that from the refrigerator, and then we're gonna use that as an irrigation solution. That is quite effective. And then based on my limited experience about for the last 4 years, I witnessed a lot of post-operative pain complaint was dropped, significantly dropped. So I sincerely recommend you try that. All right. So this is my humble idea how the heat generated during the osteotomy. So if we are drilling high speed, high RPM, it's going to be more heat. If we're drilling longer, it's going to be more heat. If we press harder when we're drilling, it's going to be more heat. If our drill is dull or the bone is very hard and more resistant, there's going to be more heat. However, if we put the irrigation, then they're going to decrease the heat. So those drilling RPM, time, pressure, resistance, irrigation, those are my equation. And then when I published this, and then my friend asked me that, hey, then let's using the slow RPM, then we're going to decrease the heat. But problem is when we decrease the RPM, then most likely we have to drilling longer. So drilling time is going to be increased. So if our drill is moved slowly, so we have to press more pressure, and it's going to be the more heat. So it's going to be even worse. We discussed a lot, then we ended up have a little experiment altogether. So to find out that what is the effect of those, the heat effect of the drilling speed, RPM, on the heat generation, I'm using the two group. First group is a conventional, 1200 RPM from the beginning to the end. And then one thing is we do the lengthening first and then diameter later. So that is a conventional way. If our target is 4.5, 11 and a half, and then we do the lengthening first, and then also we do the diameter later. This is what I learned. This is what I've taught my residents. So this is very conventional, high speed, lengthening first, and then diameter later, right? And then comparing group is I'm using the 800 RPM for the initial, and then the other one I'm using the very small, the slow RPM. And then the difference is this, I'm using the widening first and lengthening later. So that's the difference, widening first and lengthening later. So I slightly twisted it, and then with a slow RPM. So in this case, I'm using the 24 artificial bone block type 2 and type 4 bone, and then I did that on the bench test, and then I did not use any of the irrigation solution. So when I'm doing this, I'm using the thermal camera, and then also the also those the heat the measuring device, and then make sure we measure the proper heat altogether. So it ended up type 2 bone, soft bone group, I have a high RPM, diameter first and lengthening later, or slow type soft bone with a slow RPM, diameter first and lengthening later. Another group is I'm using the type the hard bone with about 1.5 millimeter of the hard bone layer, and the high RPM, slow RPM, and lengthening first or diameter first, those things, right? So, this is what I did. In the clinical experiment picture, you can see I do the osteotomy, and then when I do the osteotomy, I video clip it. In the middle picture, you can see that the tip of the drill is really hot, and also you can see those hole is really hot too. So once I capture the highest number, and then I measure the software, the temperature on each side over here. So this is how I measure the temperature created by each drilling, all right? So when I look at when I look at the soft bone group area, as you can see over here, I don't see any difference. In other words, the bone is very soft. So whether you have a high speed, slow speed, it grind it. And then whether using the drilling diameter first or whether using the lengthening first, no significant difference at all. The bone itself is very small. So bottom line is when you are dealing with a soft bone, no matter what, the heat is hardly generated. Okay. However, when we look at the hard bone area, about type 2 bone situation, then whether we have a high RPM diameter first, lengthening later, or slow RPM with a lengthening first, diameter later, all of them has those crossover pattern as you can see over here, right? So what I realized, what I found is this. Whenever we're dealing with the hard bone, right, the sequence matters. So when we do the widening the diameter, most of the heat generated. So when you're comparing with the widening procedure or lengthening procedures, actually when we do the widening, we generate much more heat than lengthening itself. So no matter what, as you can see, all those, the group showing the higher heat generation at the end where they are doing the widening. So at the end, let's look at the bottom one over here, right? That is the orange one is high RPM and lengthening first, diameter later. And then blue one is slow speed, diameter first and lengthening later. And then the difference in terms of the temperature is about 24 Celsius. It's huge, right? Then let's look at this. How about the RPM itself? When I look at it, generally when we do the slow RPM, it generates less heat. So when I compare high RPM and slow RPM generate less heat. However, when you compare with the RPM and the sequence is more important. Sequencing is a primary factors. So even though when using the slow RPM, but if you do the diameter widening, it generates more heat. Even though using the high RPM, if you do the lengthening, it generates less heat. So in summary, when you're using the high RPM, slow RPM generate lower heat. And then when you do the lengthening, the sequence wise, if you do the diameter widening, it generate more heat, right? So now let me show some of those thermal pictures. The upper one is a slow RPM and the lower is high RPM. And the upper one is I'm using the widening first and then lengthening later. And the lower is I'm using the lengthening first and then widening later. So first is before the drilling, you can see those same. And then when I do the first drilling, both of them are generated. You can see the tip of the drill is really hot. So those are very hot. However, on the first one, I'm doing the widening first over here, right? And then you can see a little bit of the heat generated, right? Even though slow RPM. However, in the bottom one, when I do the lengthening, relatively I have a less heat generated. So once the first one is widening done, they are doing the lengthening. And then once the lengthening is done on the bottom one, they are doing the widening. Now, as you can see, when I started the lengthening on the top one, very little heat generated. However, when I do the widening on the bottom, you can see the heat generated. And then once I do the more widening, as you can see more heat over here, and then more heat. So consequently, as you can see that if I'm using the bottom protocol, high RPM with the lengthening first and then widening diameter later, then all those heat is, as you can see on those last pictures, we have a high possibility that those bone is exposed to those heat. And then we place implant on that heat exposed bone. That means we have quite a high possibility of the very, very active osteoclast activities over here. However, on the top, when we do the widening first, there is a little bit of the heat generated. Yeah, bone is damaged. However, at the end, there's a very little heat generated. And so most of bone is already removed in that case. So when you compare with upper and lower case, which one is more safe in terms of the heat? Yes, I'm not saying those conventional way, high RPM with the lengthening first, diameter later is wrong. If you do the conventional way, opening the flap and then generate the irrigation, no problem at all. However, especially when you're using the guide case where the irrigation is not properly done, then you may consider the upper the protocol, right? We want to reduce or minimize heat generation as much as possible, right? So here's a take message. Bottom one is most of the heat generate in the first drill, right? So the point drill, whatever system you are using, the first point drill, you have to replace it. I recommend about 10 to 20 the case. I want you to buy the new point drill. I cannot say 15 times or 35 times you after using it, you have to replace. I cannot say that. It totally depends on your feeling because the point drill is most sharp drill. So when you drill those first one, and if you feel a little bit dull, then it's time to replace it. Otherwise, it's gonna generate much more heat. And also widening diameter first and increasing length later with a low RPM, I have a best result in terms of the heat generation. Very low, the lowest heat generation happened. But when you're dealing with a soft bone, in terms of the sequence, in terms of the RPM, I didn't see any difference at all, right? That is something like that, okay? So anytime loading protocol, right? As I showed you before, then if I'm using the CMI fixation, that is we control the compression and also if we control the heat, right? So that means we can decrease the damage on the bone as much as possible, right? And then also instead of using the regular irrigation solution, I strongly recommend you to use a cold irrigation solution. And then instead of using just the irrigation on the drill, I want you to direct the irrigation with the syringe on the osteotomy site. I'm going to show you later. If we do that, then I believe we can decrease the bone damage around the implant significantly. That's going to be ended up the much higher chance to maintain our initial fixation, right? So in order to test that idea, I did the clinical research and then with my resident, and I'm going to share with you now. So what I did is I pick up the 46 patient and then 5 of them is dropped. It ended up 41 patient. And then I placed the implant. And every week I measure the implant stability using the ISQ, that Austin machine, right? So usually 2 to 6 weeks, we have the so-called stability dip. So I pick up the bottom of the number and then I measure the difference between bottom of ISQ number and then the initial ISQ number. So in this case, we start with 82, but 4 weeks later, we have 80. So it decreased about 2, then it's about 2.4% drop. So now let's look at it. Overall, 41 patients, in this case, I'm using those CMI fixation concept and anti-heat, the concept, right? Overall, you can see I do not see any big drop. So about 70% of actually they are showing the increased ISQ, so no stability dip, and about 30% they are showing a little bit stability dip, right? So let's look at those stability dip case. So about 13 case during that one, but when I look at the number, ISQ drop is about -3 plus -2. So bottom line is that when you start with 85, but it ended up 80, so my initial ISQ number is 85, but 4 weeks later, my initial number is 80. Is it really, really big drop? Well, I don't think so. Maybe those 5 is within the compound factor of the error of the machine itself, right? So when I look at those non-stability dip group, and overall, all of them is increasing or maintained very well, right? So at this point, I cannot tell you why those increase even within a week, right? Maybe I measured it wrong, but bottom line is what I want to show you is that no matter how I look at it, I didn't see any big dip, stability dip, what I learned, what I have taught my resident anymore. So that is something I believe is breakthrough, then we can appreciate it, all right? And also in terms of the torque, right? Everybody was so scared about high torque, right? 50 torque, 60 Newton centimeter gonna cause a huge issue, but this is raw data over here. So some of them is a 63, some of them really high number, right? But as you can see over here, even though you have a high insertion torque, I do not see any stability dip or stability decrease over there. Because these cases, we are using the CMI concept. So those 62.7 insertion torque is achieved from the soft bone, not the hard bone. So this is another one group over here. You can see that. So even though it's a hard number, basically a high number, the insertion torque ISQ is not really dropped. So when I gather all those high insertion torque cases over here, right? But I don't see any huge compression necrosis. So this is, so my data then to support that. So in terms of the torque, the number is important, yes. However, where you get those numbers is more important. So if you get the 50 Newton from your hard bone, right, then that is not good, even though it's saying 50. But if you get the 50 Newton centimeter by pushing your soft bone area, right, less dense bone area, that is good. So the number itself is not really important. The number, where you get those numbers is more important. That's my take-home message for you. And also over here, in terms of the success rate, so we did research on the immediate loading case, but loading time is 1 to 2 weeks, or 2 to 4, 4 to 6, 6 to 8 weeks. But what they found is overall very similar and very compatible. However, maxillary, posterior maxillary, if you do the immediate loading, then many failure happen in the first week. That is very close to my clinical data too. Personally, my data is showing about 50%. So I do the immediate loading every on my mouth, except a single maxillary posterior, because when I place the implant, the maxillary posterior, and then immediate crown over there, then it is not really predictable. The pattern of those failure is basically most of my implant is more intruded, a little bit go deeper inside the sinus area. I believe once you place the implant on the posterior, that is very close to the joint, and when patient bite, there's more force on the apically, and it's going to decrease basically break the bone around here. That's what I worried about it. So at this point, I do not recommend single posterior maxillary immediate loading. However, premolar, anterior, or mandibular area is, if you have a good case selection, that is quite possible. That's my point over there, all right? So now it's 11:05, and I would like to have a quick break, about 5-minute break, and we're going to start again, all right? Thank you very much. See you in 5 minutes. Ayong, could you take over?
Sure, thank you, Dr. Park. Yes. All right, then we will take a short 5-minute break right now, and please take this time to grab a cup of coffee or snack and use the bathroom. And I will see you all in 5 minutes.
Okay, doctors, hope you have a time to stretch your leg. So now let's move on to our next topic that is about implant stability. I received many questions, right? And then at the end of the lecture, I give you all those the question answer all together. So one of the question is about the implant stability issues. So I'm going to share my experience with you about those stability right now. So what really matters is that we talk about the implant stability is really important, but the important thing is how to measure those implant stabilities is a one deal, right? So based on 2010 article, there is many different way to measure the implant stability, right? One is an invasive way, the other one is non-invasive way. But those invasive way is for the research only. For example, once we place the implant and we can push the implant laterally until fractured off, well, once we place the implant, we pushed out. Once it fractured off, well, we pulled out. We can do this for the animal, however, we cannot do in the human. So in non-invasive way, we can use those are several different way. One is the insertion torque, right? So we can measure the insertion torque. Or previously we were using the reverse torque. And also we can use the damping capacity analysis that is about period test or AnyCheck. Also we can do about resonant frequency analysis that is OSTEL or that is a penguin, right? So more the deeply when we look at more detail over here, then in terms of invasive way, what is the most the accurate way that we believe is a VAM, value of actual micro motions. I'm going to share this the concept later on. And also in non-invasive way, when I was a resident, my professor told me that tap those implant healing abutment with the tail of the mirror and you can hear the sound. So if the sound is right, you know that your implant is well also integrated. If it's wrong, not integrated. However, to me, I cannot tell which watermelon is good or bad by tapping it. So implant, I cannot do that. So the sound is some people is working, but doesn't work. So insertion, torque, damping, and then resonance. So let's look at those commercially available. So to do that, let me just share some example how we use those the OC integration degree measuring or the stability measuring way in the research area. In this case, I developed those mini implant. I placed those implant in the mouse femur, as you can see over here. That's clinical pictures. And then once I place those implant in the mouse femur about 1 month or 2 months or 1 week, 2 weeks later, then I cut it as you can see on the left, the 3D micro CT, and I pushed out. When I pushed out at some point, the bone is fractured. That is a break point of loading. So that is where those implant, the stability of also integration is the measure. This is how we use it, right? So let me just jump it. Those are kind of boring. But what I found is now we know that the rough surface, SLA surface is a lot better than RPM or machined surface. That is very true, right? So in terms of those pushing value, the rough surface or SLA has a really high value, right? And also when we look at the bone and the implant surface after the 4 weeks, you can see around the implant, you see a lot of bone left over on the SLA surface. So it has a much more bone left over that is attached to the implant or also integrated in the implant surface than that of the RBM, as you can see on the right side, right? So that is something that I can just tell you, all right? So just let me move. So those the motion surface, as you can see, very little, the also integrated value in 4 weeks. In terms of value of actual micro motion over here, how we do that, as you can see on the left diagram, there's a hammer, right? Impact hammer, and there's an implant, right? So those hammer is bang the implant, right? And then the implant is moving. But the implant is basically we're going to connect with the laser, and then when it move and those implant detect those the movement. So on the right side, you can see those graph, and we measure the amplitude. That is basically how much it moved. So that's what we call this a value of actual micro motions. However, as you can see, we need a huge the and a lot of instrument and measuring device over there, that is not clinically possible. And then I do not want to bang the patient's implant with a hammer. So those are very good value, but that is only research. right? So at this point, what we can measure in the clinically in terms of implant stability, we have some issue. No matter how hard we try, this is non-physiological force, and then it can be direct or indirect, and also there's no continuous. When patient chew, when we chew, it's a continuous chewing, and we have a chewing pattern, right? However, when we measure the implant stability intraorally, that is only one snapshot, that moment, that day, that moment, and then that is not really represent a physiological force, right? However, with this limitation, we try to find out what is the best way to measure the implant stability. First one is, yes, we discussed before, we can measure the implant stability by the torque, insertion torque or reverse torque. This case, I'm using the digital torque machine, as you can see over here. Right over here, when I do, and then it's going to measure the highest torque, and then this time is 24.1. That is my torque, right? So the torque is one thing. Another thing is RFA, resonant frequency analysis. Resonant frequency analysis sounds quite difficult, but as you can see over here, now you can hear the sound, right? When you hear the sound, this sound is because when I hit it, and then my wine glass is vibrating. When my wine glass is vibrating, it creates some specific frequency. In this case, those frequencies, hearable frequency, that's what we can hear. So bottom line is resonant frequency analysis is the machine basically puts the magnetic force on the smart pack that is connected to the implant, and then it vibrates the implant. If the vibrate is a lot, then we know that the number, we know that that implant is not stable. If vibrate less, then your implant is stable. When it vibrate, it creates a specific frequency, and then this company convert those frequency into the ISQ. That is their own numbers. And then they set the ISQ number. This is stable, this is not stable. So pretty much that is it. But when I look at the concept, and then when I use it for a long time, then as a prosthetist, I face many situations like that. When my oral surgeon refer the case to me, and then they measure the ISQ, and then ISQ number is 70 or 80, very high. But when I put the driver on top of it to put some temporary crown or remove the healing of a tooth, sometimes whole thing is coming out. So sometimes I realize that the ISQ number is not really related with the actual stability that what we want to confirm in clinic. So this is case that I try to mimic. As you can see on the middle one, there is implant, half of implant is bone and half of implant is on the air. And I try to mimic that situation. So now let's look at those video clip put together. So hopefully video clip goes smoothly. So now I'm measuring the ISQ. 63 보이세요? 보이나요? So those 66, 61 is somewhere in the medium stability based on the manufacturers, right? Yeah. However, you can see that there's no stability over here, right? So that really bothers me, right? 65, yeah, I respect the number. However, actually, this implant is not really stable at all, right? Even though the number is high. So I try to find out what is going on over here. And then I try to take the case. Here, when I hit those glass, it can vibrate, right? But now I put some Play-Doh, right, on the surface of the glass, and then I hit it. Now you can clearly see the difference, and then the vibrating much less, and then it's the totally different frequency, and then it's going to give you the false positive one. The problem is when I put my Play-Doh on the surface of the wine glass, did I increase the stability of my hold? Did I hold my wine glasses harder? Not really. So actually, without changing the stability or the tightness of holding glass is the same, only the pattern of the contact pattern changes a lot, right? And how about the situation? In this case, I try to mimic the those horizontal defect, especially when we place the immediate implant placement, then we see a lot of the bone defect, and then we put some bone graft around, as you can see over here. So this experiment, I would like to test that the effect of the bone graft on the RFA value. So let's look at it. So over here, I intentionally placed the implant with the large, the huge oval osteotomy. So as you can see, about 60% is really huge. You can see huge gap between the implant and then the bone over here. And definitely, I don't have any torque, very little torque. And when I measure it, it's 28, very low number. So low torque, low ISQ, fine. Then I put some bone graft over here. And then I'll gently clean it. And then I put it back gently and I measure it. Now, as you can see over here, it just ended up 28 to increase the 48. So question is, did I really increase the torque? We know that just adding the the bone graft material around it will not change it. So over here, as you can see, I can very easily remove that implant with my finger, right? So bottom line is this: when we have a bone graft situation, then those wet powder, wet particles on the contact on the implant surface, and they're going to compromise the vibrating. So then vibrating is changed, and then also the frequency change is going to do the first positive one, right? So that is a limitation of those RFA, the resonant frequency analysis systems, right? So I'm not saying those Australia Penguin is bad. Those are really great machines if you look at the long term. However, keep in mind, there is a possibility that your number can have a first positive one, depend on the bone defect pattern, right? And especially maxillary anterior, and also it's going to first positive impact from your bone graft material around the implant, right? And also the RFA, the companies, they claim that they are really the proportional, what they are the correlated with the value of actual micromotion over here. On the graph over here, displacement over from 0 to 2500, and the implant stability ISQ number is 40 to 90. So this graph showing that, nicely showing that if you have a high ISQ, you have a very little displacement. If you have a low ISQ, you have a high displacement. However, if you look at the number more closely, right, you're going to realize that that displacement number is basically 2500. That means 2.5 millimeters. So we don't need to measure those 2.5 millimeter movement, right? Even this we can see with our eyes. So I don't have to measure it. So what really matters is about 50 to 150 micrometers where those osteoblast is working properly, right? So when I look at those area 50 or 150 micro areas, then I see only 7 dots, and then I don't see any strong correlation. That bothers me a lot. So my point is this, I don't have any complaint about the article. However, the way we interpret it, the way we digest the article, we have to be careful for that. Now let's look at the period test. That is a damping capacity analysis. So damping capacity analysis is like that. When you have a target over here, and then you're going to bang it. When you banged it, and then target going to be pushed back and come back. If your target is strong, it's going to return very quickly, right? But if your target is not that strong, when you punch it, it's going to be back and come back slowly, or it never come back or knock out, right? So basically, damping capacity analysis is really measuring the returning time once I hit it, and then the target, how soon it's gonna come back. So those damping capacity is one of the way to measure the implant stability, especially for the lateral force, right? The period test, they made their own value, period test value, PTV value, and then what they're saying is negative is better and positive is bad, right? So they developed this machine to measure the natural to mobility previously. However, they changed the protocol a little bit, and then they claim that they can use this for the implant case. But the problem of those cases like that. 6.1. 6.1. Hopefully you can hear the sound and then the video clip very well. So bottom line is patient hate it, right? Because to measure one time, I have to hit the implant 16 times. So if you want to measure the 3 times, you have to bang the implant 48 times. And then the force is not really gentle. It's sometimes patient complain of the pain, what those bothering, scaring sound is really big matter. That's why rejected by the patient. And also, when I look at from the dentist point of view, when it hit the target for 16 times, you have to hold very steady. If you change your hand position angle a little bit, then the number is not accurate. So reproducible is big issue for this machine. And also based on my limited experience and research, if I measure the 4 times with this period test, and actually it's going to decrease the whole implant stability in terms of the torque and also the ISQ. So it's not really great, okay, in a way. However, from the researchers' point of view, this is very direct way, because when we have a target, actually we hit it, and then we can see how strong those target in terms of the lateral force. So that has a really great value. So if I have a controlled environment control set, this is a great way to measure the implant stability in the animal study or in vitro study, but not human being. Until NeoBiotech has this AnyCheck machine. So AnyCheck is basically same with the period test. The concept is very same. However, the difference is that they decrease the percussion force about 30%, and then they hit the target instead of the 60 times, only 2 to 6 times. So if those target is below than 60 IST, implant stability test number, it hit only 2 times. If it's more than 60, and it's gonna hit 6 times. So there's also many built-in protective figures. So let's look at this one. So now you can see 6 times is 61. Now we need 2 times, 59. So bottom line is this machine is very sensitive, and then if those setting the number is too low, and then when you hit it, the target is not really strong, then it's going to reduce the number, and then it's going to tell you what is going on, right? So, and also it is this large, and they're going to give you those red or the yellow line, and they're going to give you some the safety figures on it. So with those 4 machines, I'd like to know that which one is reliable, which one is not reliable. So I do a little bit of experiment with those 4 machines, right? So basically, I try to control those osteotomy. When I control the osteotomy on the blood and the bone, and then I can control the torque. So where I'm going to use the under osteotomy or the over osteotomy, and then tapping or non-tapping. So I spread our torque. Insertion torque is from the 5.7 Newton about 67 Newtons, like that. So I'm using the torque, and I'm using the RFA, using the osteo motion, and I'm also using the period test AnyCheck, right? And then see how they are going. So those are what I do, basically, the torque, and then the period test, and then the osteo motion, and then those things measured. And then we look at those, and then also I measure some clinical data, and then see how it goes, right? So bottom line is this: when I compare those insertion torque and then osteo, I try to find out the correlation between those two. However, unfortunately, those correlation is very weak, right? Those regression number 0.5 means that about less than 25% is if your insertion torque is increased, your osteo going to be increased too. So that is not really clinically meaningful. However, without any correlation, but I look at those numbers, the threshold number. What I realized that if the insertion torque is more than 15 Newton centimeter, then any group more than 15 Newton centimeter insertion torque has about 96% of those, the group choosing the more than 60 ISQ. So this is kind of my threshold theory. If your ISQ is more than 60, then about 83% of all groups choosing more than 50 Newton centimeters. In other words, when you need to compare which one is more safe clinically between Ostel 60 ISQ or torque 15 Newton centimeter, then the common area is much larger in torque areas. In this case, I prefer to the torque, right? Because torque has a more safe in a way. In this case, period test and insertion torque, I look at those two relation, and then those insertion torque and period test, and then as you can see, 91-96%. So this one shows a better correlation between torque and then the period test value. But here, if I need to choose, and then in this case, period test is better. But this, keep in mind, this is a experimental situation, in vitro situation, right? And then now I look at the period test and ISQ value, right? So the lower number of the period test is better. In this case, about 99% of less than 5 PTB has more than 60 ISQ. So overall is period test is inside of the Ostel machine. So if I need to choose one, then period test is safer than Ostel machine, right? Just in terms of the accuracy or the safety one. And then in terms of the AnyCheck and insertion torque, about 93% and about 100% of those AnyCheck values inside of the insertion torque. In other words, if the IST, the AnyCheck value is more than 60, then the torque is, all of those numbers is more than 15 Newton centimeter. In this case, if I have to choose one, then 15 Newtons, the AnyCheck 60 IST is more safer than the torque itself, right? So let me just, when I compare with the AnyCheck and then period test, because they are very similar to each other, right? So bottom line is basically they are using the same damping capacity analysis. So those are same, as you can see. So bottom line is this, I wish and I hope find out the one machine satisfied all those common areas that going to really accurate for all of us. But unfortunately, we do not have that kind of golden numbers over here. But what I found is, if we combine those two safety measures together, for example, if you measure the insertion torque 15 Newton centimeters, and then your AnyCheck value is about 60 IST, more than 60 IST. So if your sample satisfy those two numbers, so more than 15 Newton centimeter and more than 60 IST, then your insertion torque average is 44 Newton centimeter, Ostel average is 74, period test is 0.5, AnyCheck is 67. So when you combine those two, and then if your sample, if your implant satisfy those two numbers, then it's going to be a very safe way. So especially when you're using the insertion torque and then AnyCheck, that is the highest safety. But if you do not have AnyCheck, if you have an Ostel machine, then what you need to do is measure the insertion torque, and then also Ostel, those two combined number is much better than Ostel itself, keep in mind, right? So again, we just go over there, all right? That is something that I can show you. So, but at this point, if you're using the AnyCheck, then what I can tell you based on my limited experience, and then the minimum number that you need to have is this. Your insertion torque for the immediate loading. Immediate loading for your minimum insertion torque is 20 Newton centimeter. And if your AnyCheck value is 60 IST, then you qualify the minimum numbers. Make sense? So, but you have to think about it. If you put the implant on the mandible of the first molar or the second molar that has more occlusal force on it, then you can use those numbers a little bit higher. For example, you can use AnyCheck number 165 a little bit higher, or insertion torque is a little bit higher. Then basically you're going to decrease the common area so you can be more safe way. But those 20 Newton centimeter 6 IST is your minimum numbers, right? And also when you're using the damping capacity analysis, is one of the good thing is those damping capacity analysis is you don't have to put any smart pack, whatever it is, you can just hit it. So in this case, excuse me, In this case, you can you can check the connection between your abutment and then fixture. As you can see over here, your connection is not that great. And then when you hit the AnyCheck, then those numbers going to be significantly drop. Usually you want to see less than 10 the Newton 10 IST drop when you hit the healing abutment or when you hit those final abutment. So this is going to give you the idea whether your connection is correct or not. And also in this case, when one of my residents put those crown, but before we put the crown, we measure the AnyCheck with the healing abutment on it, and then the number was 76 IST. And then my resident put the crown on it and then the screw type, and then my resident measured the AnyCheck was a 60 IST. So I told my resident something is not right, and then take the crown out and the proximal contact again, adjustment again, and put it back. So now my resident put it back, and then we measure again, is 72. So bottom line is this, those AnyCheck also give you some idea how your prosthetic, the connection is properly done or not. And also if you're using the ortho, right, treatment, if you do the ortho treatment, you can use AnyCheck to measure the implant, the lateral tooth mobility, right? So you can record it, okay? So then you can have those quantitative number, right? Instead of the 1 plus 2 plus the mobility, you can have a specific number that's gonna help you for that one, okay? So now question is how to measure the AnyCheck. All you need to do is you have to put the healing abutment in right number, so right size. What we recommend is if there's a soft tissue over there, all we need is about 2 millimeter above the gum, okay? Up to 3 millimeter. So in this case, on the medial case, we do not have any gum height. However, buccally we have a 2 millimeter. Then those 2 millimeter more than enough, you're going to measure that. And then 3 millimeter is fine, but do not go over 4 or 5 millimeter. So please put the proper healing abutment height, right? That is about 2 to 3 millimeters, right? Okay. Then once you have placed it, then the best way to measure it is you have to buccally or lingually, you have to push those the healing abutment, hit the healing abutment with the perpendicular like that, right? Well, if your gum is like that, still you can the measure with the perpendicular because those gum is not really influence those mobility or lateral mobilities, right? But sometimes your healing abutment is too low profile and then you don't have any actual wall, then you can measure about up to 30 degree, you can measure those angled measurement. But keep in mind, if you keep the implant this way or that way, if you put the apply force diagonally, then there has a more the counterforce force over there. So usually in a safe way, about 10% is higher than real number. So when you measure the angle, then if the number is 80 IST, for example, then actually your number is about 72. So when you measure the angle, then from the beginning to the end, keep measuring the angle. Well, sometimes your healing abutment is too low, you don't see any angle, right? Or any the almost equigingible for your healing abutment. In that case, you have to replace healing abutment. Well, you can measure the vertical movement, but that is a different story. Okay. So in terms of the AnyCheck, the learning curve for proper measurement, yes, you have to practice a couple of times, and then you have to measure how to. You have to practice about 2 to 3 times to hold your hands steady, right? And then I would like to measure the 2 times. If you measure the 2 times and then the difference is less than 5 IST, the average is your number. But if the difference between 2 measure is more than 5 IST, then I strongly recommend you to the third one. And then usually those 2 out of 3 is very close. That is your numbers. And then most important thing is this. Whether you're using the AnyCheck or Ostel, Penguin, whatsoever, what is most important one is the torque, your insertion torque. If your insertion torque is less than 10 Newton centimeter, then it's already sick. It's already bad. Do not change it. Do not touch it. Do not put smart pack over here, or do not put healing output and then touching with AnyCheck or whatever that is. So if your insertion torque is less than 10 millimeter, or your implant is a spinner, or if a bouncer, then forget it. It's already bad stability. All you need to do is leave it alone, or you're going to remove that implant and put another implant. So my bottom line is measuring stability, you're going to measure the stability only your implant is okay. If your implant is already sick in terms of the insertion torque, then do not touch it. So bottom line is this. As a clinician, what is the most important stability parameter? Why should I look at it first? Insertion torque. Torque is the most important one. But insertion torque is measuring only those rotating force, right? So to measure the lateral force, how it moves to the lateral, and then you need to have a secondary one. In that case, AnyCheck is a great value over here. So if you measure the insertion torque and AnyCheck all together, then I guarantee your implant stability is quite reliable, and then you can really feel comfortable with the numbers, right? Insertion torque and then the AnyCheck value over here. So this is one of the protocol. If you want to deliver the final processes within 4 weeks, then you do the surgery with guided surgery, and then 1 week follow-up, AnyCheck, 2 week follow-up with AnyCheck, 3 week follow-up, AnyCheck. Good thing is when you're using the AnyCheck, you don't have to remove that healing abutment. You just tighten them with your finger and then check those AnyCheck with the stability. And then if those value is not decreased or is increasing, then on the 4th week, you can deliver the final prosthesis, right? That is one thing. If you want to use a final prosthesis delivery within 4 weeks. However, in the anterior case, personally, this is posterior, I'm okay with it, but anterior portion, I want to have a temporary implant crown for the soft tissue molding and those soft tissue response. So you have to use those concepts depend on your clinical situations, right? One thing that I can tell you about this, here I showed you that if you want to do the immediate loading, this is important, right? But another thing is this, how about your implant is already placed, right? Well, some doctors already placed about 3 months ago, 5 months ago, patient referred to you, then now you're going to do the crown on top of it. But you have no clue, you have no history about how that implant is placed, right? In that case, how do we know that 3 months is old implant is ready to put some crown on it, right? Here's my simple way. The best way is this. First, you have to take the x-ray. Okay, PA is fine. If you have a CBCT, that would be great, right? So make sure there is no significant bone loss or defect around that one. Second thing is this. You're going to apply the reverse torque. You're going to apply the reverse torque 15 Newton centimeters. Okay, 15 Newton centimeters. That is not a lot. If you feel really bad about it, even you can do the 10 Newton centimeters. So based on my research, if you do the 10 Newton centimeter reverse torque, that means once you apply the 10 Newton centimeter, if your fixture is not moving, hold it, stop it. So you just want to make sure your fixture is moving or not when you do the reverse torque test. Think about it, 3 months later, and then you apply the 10 Newton or 15 Newton centimeter torque, reverse torque, and your implant move, then your implant has some problem in it, right? So you don't want to put any crown on it. At that point, you're going to remove the implant, or you're going to put some bone graft over there, or you're going to put it back. So anyway, based on your clinical judgment, you need to do something on that point. But if you apply the reverse torque, no movement, and then if you do the AnyCheck value that is more than 60 IST, then you are ready to go. So definitely I can put my name on it. So reverse torque, 10 Newton centimeter plus 60 IST. If you want to be more safe, and 15 Newton centimeter reverse torque, and then 60 IST is what you need. Then those, if you pass those two, then you feel very fine to move on the crown on top of it. But one thing you have to remember is this. Whenever you put some crown on the lateral incisors, right, or anterior, and then those bones itself the bone is not, sometimes it's not hard, bone itself is really flexible. In that case, you're going to use AnyCheck value just 6 IST, but if you place the implant in the hard bone area or mandibular anterior, then you're going to expect about 70 IST. So depending on also bone quality, you're going to look at those AnyCheck value differently, all right? So bottom line is this, if you're using the insertion torque or reverse torque and using the AnyCheck, then you have a very reliable stability value. And then those stability value give you very quantitative value, then you can rely on it. That is the take-home message for you. And then if you have the Ostel machine or different machine, don't throw away, still using it. Using the Ostel machine once a month, and then make sure when you're using the Ostel machine, also you're going to do the reverse torque too, okay? So those, and then also insertion torque too. So when you combine those two values, it's going to be much better. And also now more and more the research data showing you that paper showing you that ISQ value, the Ostel value, and then the AnyCheck value is very similar to each other. It goes very well. Only difference is AnyCheck actually hitting the surface of the implant, right? So it has a more direct measure, and also AnyCheck doesn't have to put some smart pack on top of it. So to measure the ISQ, what you need to do is when patient comes in, you have to remove the healing abutment and then put a smart pack on it, and then you have to measure it, and you have to remove the smart pack and you put the healing abutment. So usually it takes about 5 to 10 minutes, depending on situation. However, AnyCheck, when your patient comes in with your screwdriver, just tighten up with your hand or healing abutment and then measure it with the AnyCheck, the healing abutment, it can take about 30 seconds. So from the clinician convenience point of view, you have every reason to try those AnyCheck too. So again, we just talk about the stability in terms of the torque and in terms of the lateral force and RFA. Hopefully this is going to give you some idea, right? So now we're going to have another break, very quick break, and then we're going to move on for the CAD/CAM guided surgery. Thank you very much. Ayan, could you take over, please?
Sure, Dr. Park.
All right. Okay. So Ayan, could you stop the sharing? Thank you. Okay. Okay, in about 1 minute, I'm going to start for the CAD/CAM. So it's already 2 hours past, so let's get to the business. Everybody is waiting for the CAD/CAM lectures. Okay, doctors, I know now you're tired. It's been 2 hours already. We started about 10 o'clock. Now it's already getting to the 12 o'clock. So my goal is try to finish before 1 o'clock so we can have a lunch in the Sunday. All right, so let me move on. And then also usually this lecture is including the hands-on, right? So if you want to have a hands-on, then please contact your sales rep, right? And then they're going to visit your office and then they're going to go with you one by one and then do the hands-on all together. And also I'll help you too. Okay. So now let's move on to the our CAD CAM, right? So to start that, I have to share with you very briefly about the terminology for the digital dentistry, right? To discuss about the CAD CAM, what is the guide surgery. First one is a CBCT. We know that CBCT is a three-dimensional radiograph. This radiograph is a three-dimensional, and also the length and the angulation is quite accurate than what is we see in the patient's mouth. But whenever we do the CBCT, we have a DICOM file. And second thing is with the intraoral scanning, right? The I500 or the Omnicam, whatever your system you have, right? We call that the digital impression. Then when we have a scanning, it's going to create the file name is STL, right? So DICOM is from the CBCT, and then STL is from your scanning. Keep in mind, right? And then those scanning is nothing but an impression. When we do the alginate impression, we are using the alginate. When we are using the PBS silicon, we are using the PBS. When we are doing the intraoral scanning, we're using the photos. So to have a three-dimensional impression, we took the 100 or thousands pictures and then the software composite, and it creates a three-dimensional shape, three-dimensional image of your tooth, right? So those are nothing but a photo impression, okay? And also, I want to share with the name of the scan body. The scan body is like that. When you have a conventional impression, implant impression, we have a transfer impression or we have a pickup impression copying. Scan body is a digital impression copying. So when we're using the scan, we're using a lot of photos. As you can see over here in the bottom picture, you can see white thing over here. That is a scan body. When the intraoral scanned it, and then the software recognized that the bottom right pictures like that, that is STL file, and then it recognize a pattern. Then software going to tell you that hey, this is a NeoBiotech IS3 5x10, for example, like that. Then you have a information about those the inside of the bone and then fixture position inside of the bone like that. So CBCT, intraoral scanning, and scan body is something we have to keep in mind. So now, why this is a CBCT or why I told you about the DICOM and the STL like that. In terms of the above the gum, including the gum, that is the STL. That's a digital impression. Well, in this case, you're going to do the regular conventional impression, and then you're going to pour the stone, and then lab going to scan the cast. That is also STL. So whatever the scanning is above the gum, right, including the gum, and also below the gum, about the bone and nerve and the blood vessel, is about the DICOM, right? So we have an upper world and we have a lower world, keep in mind. So two, STL and then DICOM is an essential ingredient if you want to have a good guide surgery, right? Then digital implant dentistry in terms of the definition, well, we have on the digital, we have an input. In this case, we have an input that is for the DICOM from your CT, and then oral scanner that is STL, or facial scanner. In this day, we choose the color too, so we call it not STL with OBJ. So those three files is our major input, DICOM, STL, and then the OBJ file. With those information, we processing it, so-called computer-assisted design CAD. So during that one, with this program, we are using the virtual surgery, virtual restoration, and also virtual smile design. With that virtual the surgery and restoration, we do the output that is computer-assisted manufacturing. So we can do the 3D printing for the guide or even the crown, or we can do the milling, right? That is output. So basically, simple way is input, processing, output, and input. The most important two ingredient is the DICOM and STL. But keep in mind, all those procedure is computer assisted. However, still our computer is not that high level of the artificial intelligence. So operator is human, is you. So in each procedure, you have to tell the right order to the computer, right? In other words, you need to tell the computer place the implant that way. Then your implant, your software going to plan based on your order, and then they make the guide to make your order come true, right? But your computer, your software will not tell you that what is the best implant position on tooth number 19. You have to decide it. So if you do the CBCT intraoral scanning in your case, and then we're going to do the virtual surgery, and then we can make the guide, and then you're going to put the implant, and then it's necessary if you want, and then we can make the immediate temporary crown altogether. So when you receive the guide, you can get the temporary crown altogether. And then once bone or the soft tissue healed, and then you're going to do the another final scan that is using the scan body, and then you're going to deliver the final prosthesis, right? That is the main deal. Sometimes people confuse that when they planning it, they only when started, we using the intraoral scanning, so they don't think they need to take another intraoral scanning. However, the early stage is for the planning. So there is always error between what we planned, what we placed. That's why it is very important for you to the scanning your implant position with the scan body after it placed. So keep in mind, right? And then also in terms of the expire date, then people believe that it's a digital, so there's no expire date. That's not true. When you make the soup, you want to use a fresh ingredient, right? You want to have a fresh onions and then fresh beef, whatever, right? Same thing. In the CBCT, I strongly recommend you to within 1 week, even though I put it within a month. But months is also too long time for the bone can be changed or the infection can be changed. When people want to have an implant, usually we have a missing tooth over there or the tooth is permanently compromised. So it's gonna change very quickly in terms of position and then bone situation. So my strong recommendation is within a week, do the CBCT and the intraoral scanning and send to the lab. Usually what I do in my clinic is I just CBCT scanning done, and then on the internet, I send to the lab right away. And then intraoral scanning, also same thing. Once I download it, and then I just send to the lab directly. So usually within a day, I send to the lab. So I want to give a fresh ingredient to the lab as much as possible. And then once you receive the guide, and then some doctors put their guide into their drawer for 1 month, 2 months. Don't do that. No matter what system you are using, the resin guide is not really stable in a long term. So usually within 2 weeks, it changes its dimension slightly and slightly. So my recommendation is within a week, once you receive your guide, and then please do the surgery, right? So now let's use the product as much as possible, all right? And now, intraoral scanning and scan body again, only after soft tissue and hard tissue is healing, right? That because when you take the final impression, you want to make sure everything is good, same situation. Unless you make the second set of the temporary implant crown for the soft tissue molding, you can use a scan body. But usually I strongly recommend you to make sure your soft tissue and bone is healed and then take the final impressions. So nowadays, there's so many implant the guide surgery system, right? Then all of them, they're telling you that they are accurate, they're very safe, and then they speedy, blah, blah, blah. But the truth is that many of my friends still hesitate to using it. And then even sometimes I do not want to use it in that case, right? So question is, why still you don't like your implant guide system surgery, right? Guide surgery system at all, right? When NeoBiotech contacted me about 7 years ago for the development, and then they sent me that the version 2 guide system, all right? And then to be honest with you, at the time I did a beta test, and then 10 out of 12 cases immediately failed. That is about 7 or 6 years ago. And now you have your NaviGuide system is version 6. For those 6 years, I've been through so many failures and complications. And today I'm going to share with you what I've been through. Because when the beta test, when those NeoBiotech sent me those case for the beta test, and then they didn't have any protocol error, right? And then I thought there is a hole and there is a drill, then through the hole, everything's perfect, but that's not true. When before I working with the NeoBiotech, I work with Noble Biocare, and then I participated in their beta test to check their Noble clinician and then double scanning technique. Still, I experienced a couple of problems too, so I'm going to share with it too, right? So to do that, let's go over the implant accuracy and then the possible error in the preparation and possible error in the lab, possible error in the clinic, and then we're going to review some cases altogether. So how can we measure the accuracy of the implant using the guide system? So over here in the straight one is what we planned, and then the angled one is actually what we placed. In this case, we have those angulation difference is alpha, and also we have a vertical deviation y, and then also we have a horizontal entry point is x, right? The x, and then y, and then those alpha. The most important thing in clinical situation is those alpha. It can be buccolingual or it can be medial distal. But dentists, including me, we are really good at to the medial distal. What really bothers us, what actually almost kills me many times is a buccolingual angulation time. So this is most critical value in clinic. I'm going to share. So this is a case that I have with my patient, and then this tooth is not serviceable, so I pull out and then put some bone graft over there. About 2 months later, I placed it. So I take the panoramic radiograph, and that is good, and I put some PA, and then I even put the abutment on top of it. I was very happy until I take the CBCT. This is a CBCT. Once I look at this CBCT, all of a sudden, all the questions came to my mind. It's gonna be okay? My buccal is too thin. The bone going to be okay, right? Do I have to tell my patient about this? Well, do I have to open it, put some bone graft over there? So on that night, all of a sudden, I have a lot of headache. What should I do, right? But when we look at more closely, this is what I wanted to put it, right? But actually this is what really placed it. And then the alpha angulation is about 9 degrees, right? So this is very little alpha degree. However, clinically it has a huge problem, right? So this is, I place this implant with my free hand without any guide, okay? How about this? If you see this kind of case, then you can tell the doctors, hey, those doctor has no idea how to put this implant. Maybe the doctor put this implant with their foot, right? This is what doctor want to put, but this is ended up, right? So the angulation deviation is about 19 degree. Oh my God, right? And the 1.5 degree. So who placed this implant? I did. So I opened it, I did my best, but sometimes it happened, right? So bottom line is this, I'm not really bad dentist, but if this kind of case happen 1 out of 100 your implant case, well, 1 out of 200 your implant case, right? That is less than 1 point. If you have this kind of case, less than 1% in your clinic, that 1%, that 1 out of 200, that bad case going to ruin your day. And all of a sudden, the other 199 great implant is not meaningful anymore. This one bad implant going to give you a big headache. So my point is why we are using the guide. My point is very simple. Let's try to minimize those unnecessary or preventable the error as much as possible. How about this? This is implant, but I placed on the bottom right, 3 implant, right? Looks great. However, when you look at more closely, all of the 3 implant has really parallel to each other, right? However, it's opposite angulation, right? Because I'm using the snap. So this wanna give me a headache too, right? I didn't want to tell my patient about what is going on, but I don't feel comfortable whenever I look at this radiograph. How about this? I want to place the implant in the septa area, right? My oral surgeon or perio friend told me they're using the fishable round bore and then and then utilize those septa, right? Then you can engage the bone very clearly and then effectively, so you can place implant in the center. But no matter how hard I try, many times my implant placed in the distal root area or the medial root area. I never get the perfect center area. Sometimes I lose all those receptors too. So can I handle those cases with more predictable and then with more safe and then with faster? Well, depend on in 2016, there is one article showing that they just compare that very experienced doctors, oral surgeons, and then they do the bench test with the guide and without the guide. And then they look at those alpha, buccolingual alpha, and then they found out that even though it's a bench test, a single implant is very straightforward. However, if they are using the guide, and then the alpha degree is about 2.19 degree. So basically, the error decreased about 3 times significantly. So whether you have a very experienced surgeon or not, whether the case is very simple or not, we have every reason to using the guide, right? We agree with that, okay? But what really bothers me is this. About 2014, there's an article about it, and then they just look at 73 article, and then they try to find out the average error for those guide systems error. So this case review, what systemic review is that they went over all the case, and then they tried to average of the errors in the entry point apex angulation, right? 1 millimeter, 1.2 millimeter angulation, 3.8 degree, not bad. And then what they're saying is this: if your implant is linearly, error is within 2 millimeter, that is acceptable. In other words, when you plan to the guide surgery, your safety margin is 2 millimeters, right? Okay, I can go with it, right? But nowadays it's close up to 1 millimeter NeoBiotech system, right? But what really bothers me is this. Angulation average about 3.8. However, the range is from 0 to 24.9 degree. Even though you're using the guide, how possibly you can have a 25 degree deviation in terms of alpha, right? You remember my case with the 19 degree, right? Really bad case, that is 19 degree, but 25 degree, is it really possible using the guide? Answer is yes, that is possible, right? I wanna share with you that, okay? So in terms of the overview of the workflow, if you have an intraoral scanning, you do the exam, treatment planning, CBCT with your patient, take the CBC intraoral scanning, send to the lab, and then lab going to do all the work. You get the confirm the report, and then you do the implant surgery. If you do not have an intraoral scanning, you can take the conventional impression. In this case, you want to use a PVS impression, and do not pour the stone. Excuse me. You're going to send your CBCT DICOM file and then impression to the lab. And lab gonna pour the stone, and then they're gonna scan the cast, and then they create the STF file, and then they're going to do the exactly same procedure. So if you look at those guide surgery, whether you have an intraoral scanning or not is not a big issue, because from your point of view or doctor's point of view, the patient point of view, is very similar, right? So now where those error can be happen. The first one is a case selection, right? You need to keep in mind that your guide going to be sit on the neighboring tooth of your target implant position site. So if a neighboring tooth is mobile, your guide itself is mobile, then your implant position going to be wrong, right? So make sure your neighboring tooth of implant site is not mobile. If a neighboring tooth is mobile, for example, you're going to put the implant first molar, right? But your premolar is mobile, then you're going to extend your guide up to the incisors or contralateral side of the canine. So make sure you cover the unmobile, the stable tooth, and then your whole guide going to be is not mobile. That is number one, keep in mind. Second thing is, if you do the full edentulous case and your soft tissue compression is about 1 to 2 millimeter, there is a very high possibility of that error. So be careful of the full edentulous case. So my recommendation is make sure you have a proper experience with a single and then multiple case, then you can move on to the edentulous case. And also, when you're using the PBS impression, make sure you keep block out the undercut. I do not want you to recommend arginine at all. I want you to use a PBS, right, or silicone impression. That is, and then the quality going to be very close to your crown and bridge qualities, right? So sometimes those when you have a full mouth impression, then the PBS impression locked in patient's mouth, and then you have to cut the tray piece by piece. You don't want that. And the other important thing is make sure when patient open, and then from the incisor edge to incisor edge, make sure it's about 45 millimeter minimum. Why? Especially when you do the first molar or second molar, when you place the implant with a guide, and the patient need to open wide. Usually you're gonna put the implant about 10 millimeter, right? And then your guide is about, thickness is about 9 millimeters. And then on top of the fixture, you're going to have a handpiece, and then also you need to have those mounting component. So it ended up you about 30 millimeter of the space, right? So if you do not have a space, you cannot use a guide, especially when you do the second molar case, right? So those maximum opening is really critical, all right? And also second thing is, another thing is make sure your patient has what kind of restoration, how many implant that patient has. Why that is important? Because more and more metal zirconium restoration and also implant, right? The titanium in the patient's mouth, when we do the CBCT, everything going to be backscattered. I'm going to show you very soon. So those, once the backscattering happens, then the quality of your CBCT is dropped, and then the accuracy of your guide is dropped. So depend on how much restoration your patient has, how much implant you have, right? You have to change your CBCT parameter, and also you have to change your field of view, FOV of your implant, of your CBCT. So mobility, as I showed you before, right? And then this is how we're going to the block out. So you don't have to be beautifully block out. With the utility wax, just block out. I don't care about the cervical area, lingual area. What really care is the occlusal area and incisor area. Make sure there is no utility wax on those areas, because that's where your guide is seated, right? Sitting on, right? Arginate, do not use it, okay? And then if you have a single case, right, two-sponge situation, like you have a second premolar, you have a second molar, you're going to place on the first molar like that, and then three-way or triple bite impression is more than enough, as you can see. So based on my 5 years experience in the single case or two-sponge situation, this is more than enough, very accurate. So you do not want to take the full mouth case impression. However, if you're going to the distal extension case, right, for you going to put the premolar, molar, right, or the full mouth case or both bilateral, then you definitely need a full arch impression, okay? Keep in mind. And then cone beam, let's just move on, because next week I'm going to have a very intensive cone beam seminar with Ray America. So you're more than welcome to join. Those are complimentary. So there are going to be 3 more speakers join together. Then we're going to discuss about the CVC more deeply, okay? But bottom line is we talk about the DICOM file, right? So once you receive the DICOM file, it's the files, right? Each DICOM file is each patient, each case is about 250 or 600 DICOM file in it. You have to send all those cases to the lab. And then also field of view. That field of view is how big your CBCT can capture it, right? For example, like that, okay? So the larger the better. Well, that is not really true. It depends on what you want. So make a simple way that if you want to place the implant on the bottom over here, right? Just one single implant on the first smaller side, right? If you take the whole pictures, right, then you need to increase the radiation, right? And also if there's any the metal or the zirconia, you have a more scattering on it. So, make it short, if you want to place one implant on the mandibular first molar, all you need to do is mandibular first molar, 1 quadrant CBCT. That's all you need. You don't need to take any CBCT on the upper one or the other side, those things. So FOB, make it as small as possible to capture the area of your tooth, right? right? And then the second one is this. You want to remember those voxel size. Voxel size is the smallest unit of the three-dimensional images, right? So when you have a TV, so if you go to the Best Buy, it has a 4K or like 8K. Basically, we're talking about the pixel. The smaller the pixel, then you can have a more higher resolution. Same thing. If you have a smaller voxel, we have a higher resolution. So the problem is when you do the three-dimensional reconstruction with a guide case, right, then make sure that your voxel size is less than 300 micrometers, right? However, if you have a 50 micrometers or 75 micrometers small voxel size, and your data going to be too big, and then your software cannot handle it. So my recommendation is for your guide case, when you send to the image center or when you take the CBCT in your office directly, then my recommendation for the voxel size is about 150 micrometers to 300 micrometers. No more than that, no less than that. That is perfectly fine. Okay, do not, right? Like that, right? So, and then another thing is when you do, let me just go jump to 300 micrometers. So now I talk about the scattering briefly before, right? Here's on the upper one, you can see those original shape. Those are all metals. One is a ring, perfect circular, three dot, right? However, once those things exposed to the X-ray photon on the image, you're going to see in the bottom, that is a backscattering, right? Beam hardening, right? And then the edge effect, all those things, basically going to distort your original image. It ended up, you cannot see where is your tooth, where is your bone, where is your nerve over here, right? Keep in mind. So backscattering, so-called metal artifact is something we have to remember it, okay? So many of the CBCT company has those function to reduce the backscattering or metal artifact, but that is not really fully remove all those the noise over there, right? So this is my case. I placed those two implant maxillary before, and then patient came to me another implant on the opposite side, the premolar. But when my assistant took the CBCT, my assistant took the whole mouth CBCT, and as you can see around the two implant, there's a lot of the lay, right? A lot of noise. With this noise, I cannot tell where is where, right? Because once already X-ray photon hit those titanium, there's a backscatter, and then it basically cause a huge noise like this, right? So what is the best way to prevent this one? Unfortunately, we do not have any solution. Maybe metal artifact is a possible partial solution. However, the only way we can do is we make our FOB as small as possible and then avoid those heavy metal artifact area as much as possible, right? That is the only way that we can do. And also, whenever you or your assistant take the CBCT, make sure that your image is okay. In this case, on your left, you can see the central incision, you can see the two line over here, right? So that means when patient take the CBCT, they moved, right? So based on this 2006 article, patient move about 1.5 millimeters, and then when we gently breathe, we move about 6 millimeters, right? So it is important for you to train your assistant, and then when scanning is done, actually 6 seconds or 12 seconds, make sure you guide the patient properly, and then make sure minimize the movement as much as possible. So once you ask your assistant to take the CBCT, and then please take about 30 seconds to 1 minute to check the mobility or the, the double line on your CT. So make sure your CT image is not really doubled. If you send those doubled images, you cannot get the proper guide case because they don't know which one is your tooth, right? Okay, so let me jump for that one. So patient movement is quite a big issue. So the training is really important. And also I want to point out that the quality of your CBCT images in terms of the contrast, I will not go very deep because I'm going to do another CBCT symposium webinar next week. However, as you can see, the yellow line is the outline of your the STL. And then you can see the background is a CT. So it looks like they are merged together very well. However, when you see more magnify the tip of the tooth, close and close and magnify bigger and bigger, you can see that you don't see white and black. You see white, a lot of gray, and a lot of gray and black, like that. So whenever you have those gray, then we don't know which one is air, which one is tooth. In other words, we cannot tell which one is tooth, which one is air, which one is bone, which one is nerve. So it is very important for you to check the contrast of your CBCT, and then when you have a high and good contrast, that means you have a good differentiation between two anatomical structures. So whenever you have this kind of situation, your lab tech arbitrarily draw the line, then that's gonna cause your error too. And also here you can see that if you see those kind of image, a lot of dot, and we know that patient doesn't have those dot, red flag. Do not send this CBCT to the lab because it has already a lot of the noise, and how can we make the proper guide based on this a lot of compromised image, right? Keep in mind. So this is the exact, the cross view of that, a lot of the little dot, right? Then whole thing is basically dotting, and then you can see that you cannot tell the where the outline is, right? So you have to keep in mind when you do the guide surgery, you need to get the good ingredient. First ingredient is DICOM file. That CBCT image must be good. So good image ended up good guide surgery, all right? Okay, so let me just jump for that, move that. And also sometimes my friends sent me those kind of images and ask me, hey, Dr. Park, can you see where the inferior alveolar nerve is? If my friend cannot see, I cannot see either, right? As you can see over. So everything is really gray, right? There's a very little white and then black, but everything is gray. That means this CBCT has a big issue over here. There is no clinical value, diagnostic value on this CBCT. So whenever you have this kind of situation, you cannot tell where your inferior alveolar nerve is like this, then you have to call the company and then start the maintenance. Check your CBCT, all right? So again, when patient move like the three different way, right? So every movement you have to keep in mind, right? So you have, at least you need to check those mobility within two aspects of it. For example, here, cross-section sagittal view, it looks, there is no double line. However, if you look at the occlusal view of the same patient, you can see those two, those two double line over there. So my recommendation is if you have a doubt and then you're going to take the two plane. One is sagittal, the other one is occlusion, and make sure there is no double line on the tooth area. That's going to be verified that your CT is okay in terms of the movement, patient movement. Now, this is a snapshot of the three shape. Then when we make the CBCT, on the bottom left, you're going to see those kind of large tooth number 8 and 9. And then on the bottom right, you have a proper shape. I don't know, so you have a good shape of the 8 and 9. But on your right side, that is your scan from the model. On your left side, that is from your CBCT. So again, if you want to make the guide, you have to merge those two information, STL and then DICOM, right? Upper world and lower world need to get together, then we can have a whole world, right? When we merge together, then we need a reference to make sure that they are superimposed properly. But in this case, as you can see, 8 and 9 itself already has a huge difference, right? This means that maybe my DICOM file is distorted, or maybe my impression or my STL file is distorted, right? So whenever you see this thing and then stop, do not proceed, right? Because your one of your two major ingredients is really bad, or both of them are bad, and then your result cannot be correct. In this case, I don't know which one is correct or not, so I call the patient again, I take the impression and I do a CBCT again. But in this case, with the wrong image, and then when I superimpose it, you can see that the error is about, difference is about 1.3 millimeter, right? That is a difference. You don't want to proceed like that. And also when I look at that case, when I look at 11, looks it matched perfectly. But when I look at tooth number 7, they are not matching. You can see the yellow line on the buccal area inside of the tooth. So when I match the tooth number 7, then 11 doesn't match. So it's a seesaw situation. That means something is not right, whether your impression or STL or your DICOM file. In that case, call the patient again, and I took the CT again, I take the impression again, and then I have those results. Still, you can see slight difference over here. However, when I merge it, now this is a lot better. So now it's okay to move on. So keep in mind, your DICOM is from the X-ray photon, X-ray image that is three-dimensionally reconstructed. And then your STL, your model scan or your intraoral scan, that is based on your light scanning. So they are totally two different characteristics in terms of the physics. And then when they make the three-dimensional image, there is always some error because of the way they capture is different, okay? So there's a built-in error, okay? Keep in mind. So now again, I'm going to tell you that if your lab technician didn't tell you that there's some difference between your DICOM and then your STL file on your left side, and then you're going to have a really, really bad surgery case. So make sure, my recommendation is whenever you have a guide case, at least you have to ask your lab assistant or lab tech, right? Your lab tech to show these pictures. Yeah. Oh, can you show me the STL file and then the DICOM file and the merging procedure? It's gonna take about 30 seconds for them to show you. So make sure you verify that there is not a huge difference between two. In this case, I'm doing, what I did is I did the intraoral scanning with, and then also I did the CT. So now I'm merging those STL file from the intraoral scanner, and then I'm with the DICOM file from the CT. So, but when I do the intraoral scanning, what I found is you can see there's a two edentulous area, right? So when I do the intraoral scanning, my intraoral scanner machine has lost its way. So I do the scanning again and again, a couple of times, and then I ended up made up. But when I do the merging, now you can appreciate what is going on. Over here, when I'm merging those yellow line and then those CBCT image, and then you can see over here, you see that over here, there is like kind of the about 0.5 millimeter at the tip of the tooth, right? So, and then when I move on more and more, when I move contralateral side, now the gap over here is about, in the incisor area, about 0.3 millimeters. So that means one of those, the information is damaged, right, or distorted, like that, as you can see over here. So once this has happened, then you have to ask yourself, how can I eliminate the bad one, right? Unfortunately, once this has happened, I suspect that my intraoral scanning has some issue. However, I cannot 100% sure. So that means I have no choice but to take the CT again and also the intraoral scanning again. But in this case, I took the conventional silicone impression and then Podostorm for this case, right? So now, when you do the CBCT scanning, if you have an option, and then I strongly recommend you to use a blue light. Those blue light basically specifically tell you where your radiation going to be hit. As you can see over here, those blue light basically giving you where your X-ray photon hit it. So bottom line is, your assistant doesn't have to guess. They know exactly where those radiation hit it. And then sometimes I ask my patient to push the tooth over there, then they're gonna capture that area. By doing that, I significantly decrease the redo CBC taking in my clinic. So you have to consider that one too, all right? So just let me move on to just jump, right? So bottom line for those house filter unit is, house filter unit is not really good reference number for you to tell whether that is a hard bone or soft bone. It is just a reference, right? And then those house filter unit depend on how you measure it. I will not go detail. Next week, I'm gonna go detail. Depend on how you measure it, the number can be very high, number can be very low. So those are just reference. Then how do we know that the bone over there is a hard bone or soft bone, right? What type 2 bone, what type 4 bone? First, I want you to use your anatomical knowledge, right? You're going to follow that the lamina dura or you're going to find the cortical layer, then you can guess. And another thing is, I strongly recommend you to, to take the PA. So pre-surgical PA over there, right? And then your CBCT going to give you a very reliable idea how what is the density of the bone around the implant site. Okay, that is something. Do not go over the house field unit or city numbers over there. Okay, and then another thing is this: no matter what the intraoral scanner company claimed it at this time, 2020. When they scanning, when they make the curvature, for example, they are really accurate in terms of the straight line. So one quadrant is really great. But when they make the curvature on the canines, they make curve. And then once they make another curve. So when they make curve, then the accuracy, dimensional accuracy for those, the intraoral impression is dropped. Okay. So if you have a one implant over here, right? When I started my guide surgery, I thought the intraoral scanning whole arch is much accurate. Accurate is totally opposite. If you have a one implant, the molar over here, then all you need to do, CT over here, and then you're going to do the intraoral scanning only that quadrant, upper and lower. That's all you need, okay? So full mouth case, intraoral scanning, be careful. But with a quadrant, that is quite reliable. That's what I can tell you now, all right? And also in terms of the which one is more accurate, intraoral scanning or extraoral scanning, at this point, even though they are using the same machine, however, intraoral scanning, because of the saliva issue and because of the light issue and then anatomical structure issue, it is less accurate, right? So whenever my recommendation is this, whenever you do the intraoral scanning, I want you to use a retractor. Your assist is going to retract, and then your assistant going to blow the air. So keep those tooths very dry, and then you scan it. Previously, we using the powder and then we do the scanning, but we do not do anymore. But still, little bit of the saliva on the surface of the tooth going to give a different reflect of the light, and then that's gonna give you an error of your scanning STL file. That's why I strongly recommend you to use a retractor, and then your assistant keep drying on that area, right? And then you're scanning, right? So it's a two people's job, okay? Keep in mind, all right? Now let's go back, let's move to the errors over here. Even though lab technician is very well trained, NeoBiotech lab technicians are quite well trained, however, still they are not the dentist. So whenever they give you, that is a suggestion. So for example, the left one is one my lab tech suggests me, then I change into the right side. I put the longer one and then more the apical, the occlusally, right? And also over here on the molar area, my lab technician suggests this, and then I ask to move to a little bit to the lingually, and then I have a better prosthetic situation. So my point is, your lab technician, right? Our NeoBiotech lab technician give you a suggestion. However, it is your job to finalize the position, right? They are not the doctors. You are the doctors. And also, second thing is this: whenever you have a guide, I recommend first 3 cases follow that lab tech suggestion. But once you have more experience, then you're going to find your own preference. In this case, I asked my lab tech to open up those distal to have a more space and then to check the seating. And also I asked my lab tech to close the canine area to gain the retention from that. So those, where you're going to have a window, how many window also you can decide it, okay? For example, like that. So now, once you receive the case, for this case where I'm using the silicone impression, then I have a master model. So now once I receive the guide from the lab, then I just check it. In this case, it's a distal extension area, and then I have a lot of window. So now I have a retention problem. Let's look at it. So now once I put it, that you can see that there was a rocking left and right. Hopefully you can see that clearly over here, right? So now if your guide is rocking on the cast, it's end of the story. Do not proceed, okay? That means your impression is wrong or your lab tech, your guide is wrong. Do not assume maybe this gonna be fit on the patient, right? So you put it and it fit. But how do you know that that position is a correct position, right? Because everything we guide is based on the one single position, but now in the impression we have a two position intraorally. Somehow it fit, but we don't know that is a correct position or not. So from that point of view, whenever you receive the guide, and then make sure there's no rocking. That is number one. So this is a good example when you receive the guide like that, and then now you can see there's no movement at all. It's basically snugly fit. That is what you want. Every case you want to have this kind of snuggling fitting over here. And then if you have a very tightness, too much tight, then you can talk to the lab and then ask them to change it. Then they can make a little bit loose. Well, if your guide is too loose, tell the lab to make a little bit tighter and they can do that. So everything is customizable, okay? So let me just jump for the Oron 6 case. Now, what really bothers me, when I do the beta test, I didn't know about those possible error in clinic. Nobody told me that. So one thing you have to keep in mind is the tolerance or gap. So you have a 9 millimeter diameter of the female, or you have a 9 millimeter diameter of the male. Then to connect it, so whether your male going to be bigger or smaller, or your female going to be the bigger. So in other words, there's supposed to be a gap. We call that is a tolerance, right? So when we make the guide, there should be gap between guide and tooth, right? That is a tolerance. When we make the drill, there must be the gap between guide sleeve and drill, right? When we make the holder, more component, each component needs a little bit of the gap. In this case, our tolerance is very small, right? So it is accurate. The problem is intraorally, clinician going to have a really hard time to get the correct path of insertion. So they cannot make the hole. They cannot put the drill inside of the hole because of too narrow the path of insertion. In this case, our tolerance is large, right? So that means clinician is easy to use it, but problem is it's wobbling it, right? And also the tolerance is too small. From the company's point of view, high quality control is needed, right? So we have to look at both sides, whether company can do it or not. So when I studied, I thought this is what I dreamed, right? Hey, there's a hole, there's a drill, then I can put it in, I can put the hole right away. But in reality, because of there's a tolerance, it can be go this way, right? I just exaggerate too much dramatic effect. However, that is actually possible because of the gap. So 7 years ago, 6 years ago, we have no idea what is a proper gap, proper tolerance. Sometimes it was really big, sometimes it's really small, right? So I didn't know that. So that's why when your first drill is wrong position, the second drill is extremely difficult to get the proper corrected. So after 4 years later, try and error, what we found is those early engagement. Before I put it, the cylinder portion is already engaging, and then we put this way. This is what we aimed at. However, still there is a tolerance that's inevitable tolerance, right? So even though we improved a lot, but still there's a little tolerance. Okay, keep in mind, no matter what system you are using it, no matter what implant company you're using, there's always tolerance, right? The question is how they make that tolerance, right? And then also those tolerance can be supported by their quality control of the company too, right? And then those tolerance is meaningful for the clinical issue. You have to keep in mind. So now let's share my video clip. Now I'm using the 50 RPM, but here this is a bad example. When I place the implant over here, nothing is engaging. So I tried to using the slow RPM, but I tried to using my eyeball to get my drilling is correctly fit on my guide. So in this case, it's partially guide. No, hello, this is not a guide. I have to use my eyeball to fit to the guide to drill. This is wrong way. So whenever you have a freedom like this, whenever you can use your eyeball when you're using the guide, something is wrong. Stop it. okay? It should not be done. And hopefully this one, I wanted to hear the sound. I'm using the high speed, but when you're using it, when you're using the high speed, everything looks really fine. But I wanted to hear the sound. You're gonna hear a lot of metallic sound. Hopefully you can hear that. Now I'm getting in there. Nothing else about it. I'm using high speed over here. So once you're getting there, now can you hear? Yep. So that means now, because the high speed 1200 RPM, I'm grinding the sleeve and then the drill itself, right? So basically, even though I'm using the guide, I'm fighting against the guide. So whenever you hear that kind of sound, stop. Basically, you are grinding the sleeve. You are not following the proper path of insertion, right? So those early engaging is why important. When we started, we didn't know about that, those early engaging. So if there's no engaging, it's wobbled a little bit left and right, you can see. And then finally, I found the position I placed the implant. Then it's going to damage our cortical layer, and then they're going to end up our big issue later on. How about this case? This case is a full mouse case, and I did the test with this company, and then let me show you. So how about those two implant place, and then I'm going to put my final implant fix over there. So when I put it down there, as you can see, when I put it down there, then I have a full freedom. I can go this way, that way. So then I'm keep asking, what should I do? And then the company asked me to follow my eyeball and then do the guide to guide me. So in this case, I have to guide my guide to guide. You kidding, right? So again, whenever you have a freedom, red flag, okay? Do not enjoy the freedom whenever you have a guide case. So in this case, let me just go, somehow I just go in there and then I tighten up, but the torque is really high, but I have no idea at this time, this torque is from the implant or a bone, or this torque is from my drill and the sleeve. Anyway, I just torque it as much as possible. Once it's fully done, I have to remove it, but it's locked in because angulation is wrong. And then the company asked me to using the crown remover, and they yanked it out. Okay. So what's wrong with these pictures? The problem is this. If you are using the guide and then everything goes to be in the right position, there should be no locking error, right? So, but if you need to yank those component, that means your implant position is already against the guide. So this is not the guide, right? So there should be no rocking if there is no error. And then also, you should not your guide to guide you. Okay, keep in mind. And then also another one is this. This is my case. When I pull out the tooth, I put some bone graft over here, and then you can see a little bit of the bone on the buccal area. And this is my plan, and then I place the implant. But it ended up like that. My God, it's the same case. So my implant is totally out over, even though I'm using the guide. What is going on? If I do with my free hand, it's much better, but this case with the guide, how possibly it can be done like that? The thing is, I didn't realize that the importance, understanding, I didn't understand the tolerance. Here, this is what I dreamed about. Hey, there's gonna be that happen. But in reality, you put it in, you push it, follow the slippery bone area, and then you press it. At that moment, your guide going to be a little bit dislocated from the tooth because your guide also has a gap between the tooth and guide, and also there is a gap between the drill and the sleeve. That's why it can be happen over here, right? So I didn't know that, okay? So to solve that issue, now NeoBiotech, we work hard, and then what we need to do is we do the bone flattening drill before we do it, and then make sure your surface is flat, and then you all engaging, and then drill touch the bone without slipping, and then you press it. So this is very common sense now, right? This is very simple. However, to find out this, make this protocol, it takes about 3 years to solve the issue. But now, how about this case? This is my friend placed those implants on the septal area, and then it ended up like that. hey, this is where those hole is, and then now implant should be in the septal area, but it ended up distal. Nothing better than my freehand case. But question is how this is possible if even though you're using the guide, okay? How possibly you can put your implant on the distal area, the root area, right? Instead of the septal. Here's the thing. We dreamed about like that. Okay, with a guide, we can make the hole through it and then we can put the implant like that. Hello, still same situation. Even though you're using the guide, everything go that way, slippery bone, and then your guide tilt a little bit. But this tilting is not really 9 degree or 10 degree. You tilt and the guide tilt a little bit like 1 degree, it ended up huge angulation, ended up error, ended up. So you have to be very careful. Then how to solve this issue? The protocol-wise, you have to use a bone remover, okay? Bone flattener. So before you do the first drill, you have to make sure your drill is flat, your bone is flat. Once your bone is flat, then you have to touch the bone with your pointer drill with the engaging. Then you're going to place the first drill. Then you're going to do the second, third drill is properly done. Now, in this case, this is my case, and then now, as you can see, this is what I do. So basically, it's not inside of, it's middle of the septa, but actually it's more difficult. I through the septa, and then I make the perfect position. So what I can tell you is, even with my hand, with the guide, I can do very predictable result with those, the immediate placement in the septa area, right? So now, every guide system has good point and bad point. Whether you have a different company, have good point and bad point. But what really matters is protocol. Each system has its characteristic and each concept, and based on that concept, they have to make the protocol. You have a beautiful Ferrari, yes, but if you don't know how to drive it, how to deal with the Ferrari is not meaningful, right? If you have a Ferrari in the desert, what's the point, right? So you need to understand why, the purpose of your guide, and also you need to understand the how protocol of your guide system. Okay, that is more important. That's my take-home message. So all my lecture is about those protocol. Now this is my another case, and the patient came to me, and then you can see there's a huge internal inflammation. I pull out, and then I put some bone graft. I thought that was okay, so I placed the implant virtually, and then I placed it. It ended up in the buccal. The whole thing is out of the way. How is it possible, even though I'm using the guide, right? So the thing is this: whenever you're dealing with an anterior case, this is what we dreamed about it. Okay, and then to get the better fixation, usually we do the less osteotomy in the apical and the mid area, right? But the truth is, when we put it in, always we're going to follow that those hard bone area, and then basically they're gonna be always forced from the palatally. With your free hand, this is gonna happen a lot, right? With a guide, this is gonna happen too, right? This was a big headache. Then what do we do? In this case, I strongly recommend you use a full length tap. So not only those partial tap, in this case, your apical third over here, apical third over here, let's do apical third area need to be pre-tapped, and then your implant position need to be set. And then when you insert the implant, your apical third basically hold the position the way you want, right? So that's about the also protocol, how to using the small tap drill, right? Partial tap drill and full tap drill is depend on the clinical judgment. So in this case, this is how I plan, and this is how I place. Usually in the CBCT, as you can see, because of backscattering it, those titanium is about 30% bigger than actual size. But even though I did everything very carefully, but still you can see slightly buccally position, but this is quite acceptable over here. Apical thoroughly. And then also, whenever you do the guide multiple case, when I started, I thought, hey, I have a 3-hole, then have a point drill, right? So boom, boom, boom. And then second drill, third drill. Never do that. If you do the drill by drill, not a great way. It's going to give you a lot of error. What you need to do is you're going to do the implant by implant. So in this case, you're going to do the implant. So first drill and place the implant. Once your implant is good position and then good stability, then you're going to connect that implant to the guide. And then you do the second implant. You finish the second implant, then you're gonna connect your second implant to the guide, and then you do the third implant, right? Never do the drill by drill, always implant by implant. And also, as you can see, I discussed before, right? When you have a distal extension case, that upper one, I wanted to have a very long guide that going to stabilize your guide. Do not make those short guide, right? If you have those short guide, it's going to be rocking a lot. The medial distally, it's going to give you a headache. So make sure whenever you have a distal extension case, make sure you have a long guide. Cover the contralateral canine at least. And also whenever you have an anterior case, even single lateral case, I do not want you to make your guide like from lateral to a canine to canine. Don't do that. Make sure you have like premolar to premolar, very long guide. Whenever you use a very long guide, they're going to fully stabilize your guide. And then whenever you place the implant or the drill on the anterior portion, so those guide has some force against your buccally positioned the tendency, right? So keep in mind. All right. So now let's go over quickly about the case review. But this is I want to see this video clip that we are using for now. So whatever you do, make sure you're going to check the fitting with your eyes and explore in some of the occlusal surface area inside you. And tissue punch, 800 RPM. So this tissue punch is not cutter. You're gonna grab the soft tissue, you're gonna remove that soft tissue. Then as you can see, I'm using those irrigation solution, as you can see over here, right? Then this is a bone flattening drill. And then irrigate with a cold irrigation solution. And then once, make sure there is all engagement, and then still you're using the 800 RPM. Because whenever we make the hole on the cortical or hard bone area, you can use that. So once that is done, also irrigate with cold water. So this is not wasting your time. Whenever I strongly recommend you change the drill yourself, right? And then when you change your drill, your assistant irrigate. So it perfectly timing is good. So I intentionally make those threads again and again because this is very important to irrigate directly to the bone area and decrease the bone heating as much as possible, right? So now we are moving on to the diameter first. Once the diameter is done, then we are move on to the lengthening, okay? So the first part I told you about the heat generation, right? So this one is basically anti-thermal, the necrosis, the protocol, as you can see over here. Now we are increase the drilling, lengthening little by little. So once that fully lengthening is done, then what you need to do is you're going to do the tap drill. So with the tap drill, I recommend you to using the 50 RPM or 30 RPM. So I used to using the 50 RPM, but now I'm using the 30 RPM because I guess I'm getting old. So I want to be a little bit more time to get the vertical, the positions correctly. So over here, you can see those black bottom line over there, depend on the thickness or offset of your guide. You're going to stop there and then you're going to remove it with the 30 RPM or 50 RPM. And you irrigate thoroughly one more time. And then important thing is, I strongly recommend you to use your finger. So not the implant handpiece to place the fixture. So you're going to connect your implant fixture with your hand, the fixture driver, ratchet fixture driver, and then you're going to put those implant into the guide itself very slowly. And then with your finger, you just tightening. Once you feel some resistance, then using the torque wrench, and then you're going to measure the torque, the insertion torque. That is what it's supposed to be. All right. So now let me hold on. This is a case. Let me show you. So this patient has a lot of the plastic surgery before, and then she has a very atypical pain, and then she has a one implant before by other office, but she complained a lot of pain, but she came to me, and then now I'm going to share those video clip with you. So I played about 2.5 times faster than the total surgery time is 9 minutes. So once I put it in, as you can see, I check the gap between Explorer, and then now I'm using the tissue puncher, and then I'm using the bone flattening. And then whenever I do, as you can see, I always put one finger over there and then make sure guide is properly done, okay, in the position right there, right? And then I going down there, as you can see, now point drill is done there, and irrigate like that. So those irrigation, I'm using the cold irrigation water, right? And then now I do another drill like that. So let me just move on. One side drill is done, okay? So now, so once all the drill tapping is done, then now I put the implant. That is implant, and I just place with my finger. So once I tightening, once I feel the resistance, right, then I'm using the manual torque wrench. So by doing this, you can feel the bone, and then you don't have to worry about those wrong direction, right? And then I'm using the torque wrench, and then finally I get the position, I measure the torque, insertion torque, and then I remove it, okay? And then everything goes very smoothly, and then you should not have any rocking over there. And then finally I check the bone level around the implant, make sure it's good, and then now I put the healing abutment, okay? So this is an case, all right? So this is what patient has. I put some bone graft, and then this is what I placed. This is what I received from the lab. This is what I planned. This is how I placed. Now I'm going to share some bad case, right? So because bad case is more important. So now this one is what really happened is patient has a TMD issue, and then patient open wide, but very frequently close it. So during the surgery, patient bite my handpiece, and then I was shocked, and then I in rush. So even though I'm using the slow RPM, 50 RPM, but because of I'm rushed, I press too much, right? I wanted to see how it went. So when I do, when I place it now you can see that patient is almost, once I going there, and the patient is now closing a little bit. Now when I put out, it's tight. So once this is happened, then I'm in rush. So I'm in rush. So what I did is basically, now let's jump in. So now I wanted to look at my fingers. So now when I move on for the drill, and then I place a lot of force, and then you can see my finger is vibrating, right? I a lot of force apically. So even though I'm using the slow RPM, I did not give a time for my drill to cut the bone. So it ended up, let's look at this. It ended up going there and take it out. So I didn't even give a 10 seconds for the drilling because I was in rush, right? Well, the case was done, and then now what happened is here. So this is a result, and then based on my plan, and then everything goes very well, and then there is the artery was not problematic, and then the nerve is far away from it. However, the issue is next day patient is waiting for in front of my office, and then he just pointed out that it really hurt. Okay, he want me to take that implant out. Okay, the next day of the surgery. So when patient sit on the chair, and then I did not numb the patient, I just counter torque, counterclockwise about 2 turns. When I do the 2 turns, patient say, it's released, pain is gone. Okay, and then once I remove it, and then patient is gone forever. Why this is happened? Because when I place the implant, when I do the drilling, I didn't give a time for my drill to cut the bone. Basically, on the soft bone area, I crushed it. So when I crushed it, those bone is going down, and then when I place the implant, those crushed bone is pressed the nerve. So I was lucky. When those remove the implant, when the pressure is gone, the nerve stimulation is gone. So my take-home message for you is when you're using the slow RPM protocol, make sure you have a give a time for your drill to cut the bone. That is very important, okay? Right? And also now I'm going to share the case where those guide is not snugly fit. This is about second molar situation, but let's see. So as you can see, if your guide is not properly done, then every time you put it, take it out, then your whole guide is going to be coming out. That is not good, right? So even though there's arc of closure, but the problem is the guide itself is not really retentive and snugly fit. So every time I do, I have to get the position correctly, and then it was very annoying. So do not use those this kind of guide in the clinically. Whenever you have this situation, call the patient and then take the impression again, or remake the guide and then do the proper procedures, right? Okay. So now I'm going to share another case is patient came to me, patient is a dental phobic, but this is actually what I do. I do the triple impression case and then I send to the lab and the lab make this thing and then I do the surgery. So this is usually what I do in the clinic and then I put the surgical report around the table and then now my assistant is helping me and then those in the back you can see those the syringe in the back. So now I'm going to check the fitting again, and then now I'm placed implant. This patient is a really, really difficult patient. It's really dental phobic. When I blow the air, patient is already scared. But however, patient bring a lot of friends and then family members. So patient is my best patient, but patient is one of my most difficult patients to treat. But now patient want me to place the implant, right? So now this is a big issue over here. So now I just want to share some of once the surgery is done, now once I place the implant over here, so now I just using the torque wrench and then I measure the torque and then I remove it and then I put some the healing abutment and I tighten up and then let's see.
Overall. Well, I was very nervous, but it was much easier than I thought, and there was no pain, and I just felt like an old car, and he was screwing that screw into my old joints, and it was all rusty, and he had to keep on screwing and screwing. You just feel some pressure, and that's all, no pain, and it's just a very strange feeling because it's never happened before. Where somebody screwed my jaw.
How about the time? Is it durable?
Oh, yes, that it went so fast was wonderful. And everybody's so pleasant here. And he's always saying the same thing. You're perfect. It's very good. You're the best patient I ever had.
All right. Thank you very much. Thank you.
Thank you.
So my point is when you're dealing with a dental phobic patient, right? So very difficult patient, you can consider those guide surgery. Those guide surgery takes about 10 minutes if in terms of if the norm is done. So from the beginning, from the guide sitting to the healing abutment placement, within 10 minutes, you're going to finish it, okay? Your first case may be 15 to 20 minutes, but after 3 cases, you're going to decrease significantly those time, I guarantee. So now this is a case that I planned. This is how I placed, right? This is where the slope angle was there, and that is my bone graft over there. You can see that, right? And then this is how it ended, all right? So now let me share my final case with the immediate loading and immediate placement case. Patient came to my office for those immediate loading case, but after take the CT and the impression, 1 week later, patient come in, but the tooth was fractured off. But as you can see over here, there's some leftover resin over here and still root tip over there. So this is how I planned, right? Lab planned and I modified it. And then when I do it, and then, as you can see, sorry about it. As you can see in the buccal area, right? Buccal aspect of the implant, I know there is a gap. So when I planned it, I knew that there's a patient need a, bone graft over there. Then I asked myself whether I'm going to put some bone graft over there, what kind of membrane I'm using it. So in this case, I plan to put some bone graft instead of just a jumping space. And then I realized that I'm going to put the temporary crown immediately right away. So I don't need any membrane over there. So when I plan this, I call my patient and then tell the patient they're gonna be bone graft is needed, and then I already discussed with the patient. So good thing about those guide surgery, not only the implant position, but whole implant surgery procedure, you can plan it. That is something I want you to remember. So now I remove that. Let's look at those video clip. So remove those tape. So root it very carefully. Okay. I do my best to do the egg as close as possible, right? And then remove it, and then irrigate, and then remove those excessive the resin. So now I want you to look at this. This is a one letter inside your case, but look at the size of my guide. I started from the premolar up to those premolars. So this is what you need, right? So make sure you're going to maximize your retention and then stability. Make sure there's no rocking with your guide as much as possible. So once those implant is done, just let me move on for the time of being. So now, what I do, let me go up to here. So now once the implant is in, I put some cover screw over here, as you can see. Then now this is my version of the bone graft. Because once I know that there is a buccal case there, I put some bone over there. And then now I'm using the jig and then non-engaging abutment. And I put those temporary screw type of the crown right there. And then I check the proximal contact and carefully customize it. This patient wants to have matching the shade with his premolars, and then that's why I customize it for that one, right? So now I check the occlusion, as you can see over here, right? And then now with the high speed and then fine diamond bone, I'm doing the cut back. So for my final customization. Once that is done, occlusion is done, and then I do a little bit of the resin on top of it to matching the shade and texture like that, right? So flowable resin, I just make the texture and then the shape finally. But one thing you have to remember is that do not put any big contact, right? So hopefully, I recommend the no contact on the neighboring tooth, but now I put some the Teflon type over there, and then check the occlusion one more time, and then the right curing those temporary filling on the on top of the healing. So this is right after the surgery. So now what patient want is the match the shade with the second premolar. So now I matching patient is okay. Then this is right after surgery, right? And then this is before the surgery placement. And then this is placed, and then you can see the difference between two. Those are quite close enough. And then this is before, and this is about 3 weeks after the surgery. So the soft tissue heals very well, and then looks fine. So final one is this. Whenever you do the sinus elevation, you need the option. In this case, when you're using the guide, vertically your guide is very, very accurate. Even though I told you that the overall, the safety margin is about 2 millimeters. However, in this day, it's about 1 millimeter, and also the vertically is less than 0.5 millimeter. In this case, if you have a bone about 8 millimeters, well, 8.5 millimeter on the sinus area, then you have a choice whether you're going to do the crestal approach and bone graft sinus elevation and put the 10 or 30 millimeter implant in the back, or you can using those 8.5 millimeter fully, and then you're going to put the implant. In this case, I put some 2 implants, and I plan to do the spin together. That's why I planned it. So now this is how it ended. This is not a coincidence. I planned it. I want my implant is stop right under the sinus floor. Okay, so this is how I ended, how I planned, and then this is how I ended up. Okay, as you can see over here. So I'm not saying the sinus elevation is better or putting the 8.5 millimeter implant is better, right? I'm not saying that. However, this guide also give you option whether you do the crestal approach or without sinus elevation. You can fully engaging the bone without perforating the sinus. That is not possible before that. Okay, so this is the case. So the final one is your drill find its own way to less resistance. Like think about the tolerance and slippery bone. And then if you are not properly prepared and if you don't understand the concept when you are doing, basically guide surgery is blind surgery. It's gonna cause a lot of problem on it. So make sure you are fully prepared. And then also if you have time and then if you want to, then using those cold irrigation solution, they're going to help you a lot. Not only the implant surgery, any surgery you are using, or even the scaling and replay using the cold cure or cold irrigation solution, they're gonna help a lot in terms of post-operative complaining and pain and swelling, all right, like there. Okay, so now it's 1:15, so I'm about to finish my webinar at this point. And then for doctors who already voted and then who want to have a hands-on, so please contact your sales rep, and then sales rep going to visit your office, and then we're going to do the face-to-face, one-to-one, face-to-face hands-on together. And also we're going to have a small group, and then we have a two-way hands-on with the Zoom program too. All right. So it's a 1:15, and then thank you so much for your great attention, and then hopefully I can see you on next coming Saturday, to discuss about the CBCT. It's a 3-hour, very intensive and then very deep seminar focusing on the CBCT from the A to G. We're going to go all the CBCT all together, right? I know I have a lot of Q&A over here. I wish I can have a time to answer for that, but now I already 15 times is behind the schedule. But what I'm going to do, I'm going to read the questions, and then I'm going to put those answers on the website as much as possible. And thank you so much. Ayong, could you take over?
Yes, thank you so much, Doctor, for this great presentation. It's very thorough, and I hope all the other doctors will have a great time and learn also for this great our guided system. So due to the limited period of time, we would have to move on to announcements. So just bear with us in here. And stay connected with us on social media. On our Facebook page is NeoBiotech USA, and Instagram is NeoBiotech_USA. And lastly, our YouTube channel is NeoBiotech USA. And follow us, and you will see the most up-to-date of our webinars, and also the kits for the surgical kits as well. And if you are interested in taking our webinars, you can find upcoming webinars in our website at www.neobiotechusa.com, and click the education on the top, and you will see a drop down of the webinar page. So click on that and you will be on our webinar page right here. And we will have a second 2020 Eurasia GAO core member meeting virtual, and it will be taking place on Monday, June 29th. Roma time is from 12 to 3, and Dubai time is from 2 to 5. And then lastly, Korea Standard Time is 7 to 10 p.m. And it's Sunday, actually, June 28th at 3 o'clock, midnight in the Pacific Coast time. And most of the doctors from Europe and Middle East and Asia will join it. That's why the time zone is more Eurasia friendly. So during this meeting, the GAO directors and core members will share their clinical experiences and updated research data. And we are sure it will be another incredible time of learning and networking. So if you are interested in joining, please contact GAO Forum. And here's their contact information. And I will also leave this on our chat box as well. And we have another great lecture coming up on next Saturday, as Dr. Park just mentioned about the CBCT. So next Saturday, June 27th at 1 o'clock, so 1 to, I believe, 1 to 4, with the co-hosted by DeVray America on the CBCT on the topic of just a few things must be known but ignored. And this is a 3CE webinar. And we also have another webinar on Sunday, It's June 20th with Dr. Ken Huang on topic of implant, surgical, and prosthetic complication, FRSR, at 10 a.m. And all these courses are first come, first served basis, so please register in advance and reserve your spot. And if you missed any of these great lectures, or if you want to watch our webinars, you can watch it on our website and click on the education again at the top. And then you will see there is a previous webinar drop down. And you will be on our previous webinar page right here. And thank you very much for those who stayed on to the end. And one of our sales rep will email you the link to complete this course evaluation form. And this form should look like this, and it should take no longer than 5 minutes. It's very simple.
Also, Ayam, so for those questions, can you hear me, Ayam?
Yes, I can hear you, doctor.
Yeah, for the question that I didn't answer today, I'm going to send those doctors directly to the email. Okay, so I'll
Sure.
contact you and then I answer your question through email. Thank you.
All right, thank you, Dr. Thank you, Dr. Park. All right, and thank you very much for participating in today's webinar, and we hope to see you again next time, which is the next it's upcoming Saturday. So please feel free to contact me if you have any further questions. Here's my email, ayong.chui@neobiotech.usa.com, and I will also leave Dr. Park's email on the chat box in a minute. Right. And the first email, okay, here it is.
Okay, Ayong, I guess we are done, right?
Yes, we are done. I will just leave Dr. Parks your email on the chat box, but we are officially done for this webinar.
All right. So thank you very much, everyone, and then have a great Sunday afternoon, and then we'll hopefully see you on coming Saturday. Thank you so much.
Thank you very much. Thank you, Doctor, and it's your happy Father's Day to all of the fathers that is here. All right, thank you, and have a wonderful day.
Bye-bye.